Thank you very much for joining today this exciting day for us, all of us. RITMOCORE project, RITMOCORE Public Procurement of Innovation project comes to its end. It has been a long adventure for all of us, exciting because we could together with all our consortium change the way we are delivering healthcare provision to patients implanted with pacemaker, and it's now an opportunity to share our experience and share our lessons learned with all of you. Today it's we have today we have 1 second that I'm going to share my screen. We are going to have a very long day because it has been, as I was saying, a very long experience, no? And so we are also going to have a very hopefully interesting agenda with all of you. We start with a welcome from European Commission, from the officer Irina Calderon-Lival. Then we are going to have Dr. Jay Wright from Liverpool Heart and Chest Hospital explaining to all of us the relevance of addressing the evolution in the treatment of patients using or in need of an implantable pacemaker. And then we are going to have Jonas Zabalaga, that is our project manager of RITMOCORE, showing, describing an overview, short overview of RITMOCORE Public Procurement of Innovation and all the path from the unmet needs to deployment of innovative services. And finally, there is a block, where we are going to show, well, the buyer, the healthcare professionals are going to go through how these innovative services change the way in the patient experience in the case of patients implanted with pacemaker. And they're going to do this together with also the service provider that have been contracted for making this transformation. Then we are going to have also some inputs and lessons learned from one supporting entity that has been along this journey the coordinator of the procurer, Valde, Sofia Moreno. Also the experience from one of the public procurer that at the end could make this transformation and why this happened, Fernando Jara, Mutua de Terrassa. And then we are going to have also a roundtable regarding how the policymakers can boost this kind of contracts and what needs to be done to make a further boost, and what evidence this kind of contract needs to bring for boosting, for providing an evidence for the policy making. And we will have not only inputs from the European Commissions, but also from patients, from a payer, and also from a purchasing organization. So let's give now the word to our to the policy of to Irina Calderon that is joining us this morning. Thank you very much for joining us in opening this session. We are very honored to have you here. I'm going to share for you my the slides, and I'm going to mute myself. Thank you, Irina, for coming.
Thank you so much for this invitation. although I have not been the PO of this particular project, I am part of a unit in DigiConnect on responsible for policies and also research and innovation in the field of e-health, well-being and aging. And me particularly being responsible for several initiatives related to aging with digital technologies, such as the European Innovation Partnership on Active and Healthy Aging and others. I'll try to be very quick because we are advancing with time. So please, next slide. Yes, so my unit and projects also such as yours could be very well placed in various actions and strategies that the Commission has already put forward and is also currently working on. Maybe two of the biggest ones could be seen on this particular slide, the communication on digital transformation of health and care, which was published 4 years ago, with its three main objectives: to, one, ensure secure exchange of health data, which means also, of course, to make sure that this data and systems are interoperable, that the systems are secure, cyber secure, and also GDPR compliant, and also other aspects. And with a second important point being to be able to pool data together and to allow better research for better personalized medicine. And in particular, its third main pillar, which is to help patients and citizens to take care of themselves with the help of digital technologies. It's not exactly self-care, but it is to empower them to use such technologies and either prevent more complex diseases or, when necessary, monitor a complex condition or multimorbidities as well. And then the other important action that we are currently working on is the setting up of the European Health Data Space. But I will not go further into that. Next slide, please. In the last 2 and already 2.5 years, as you know, we got a pandemic in the world and particularly in Europe. Many older people were mostly affected, especially in the beginning, by this pandemic and by very high mortality. And the Commission took various initiatives and also funding instruments on how to actually address demographic change. And while demographic change has many different aspects, one that is really important is how to provide health and care to older citizens in times when there is a very high shortage of staff and even more employees in working systems leaving also their jobs and not wanting to remain there. But it's the actions that we took after the report on demographic change that went out in 2020 were wanting to address those challenges that are listed, such as sparsely populated areas where there is very low connectivity, also how to address and help citizens live with long-term chronic and complex medical conditions, how to address this increased demand of social and health care for staff, the lack of age-friendly living and working environments, and also address the digital skills for healthcare workforce, both formal and informal. As you know, informal carers are very often those involved when taking care of older citizens in particular. Next slide, please. And yeah, some of the very important points that we have seen with the various reports that came out, also on the long-term care report that was published last year, is that the number of persons in the EU that will need long-term care will rise drastically in the coming 30 years. Also because the aging population, or not so much aging, because 65 plus is very often people in very good health conditions, but they will represent more than 30% of Europe's population, and with that also the need for long-term care will rise very dramatically. On the other hand, as you know, I guess even better than me, the transition from institutional care to family-based, community-based, home-based long-term care is very slow in almost all countries. And then also there is a very high difficulty to choose the type of care for the citizen, and to make sure that it is really person-centered. Yeah, I think we could move to the next slide. And I would like to mention some of the actions from the Commission. Some of them are very old already, or better said, they are still with us since more than a decade, such as the Active and Assisted Living Program, which, as some of you may know, is co-funded by both member states and the Commission, and aims to scale up innovations for the older population. It has had some remarkable successes, with over 30 solutions being brought to the market. On the other hand, we have also supported for the last decade the European Innovation Partnership on Active and Healthy Aging, with its various previously held action groups, and also supporting the reference sites, communities, and regions that are committed to promote innovation for active and healthy aging. The Commission as a whole has supported a lot of research and innovation, including large-scale pilots, and our unit in particular in H2020, for example, had over 90 such actions that are aimed in particular to supporting innovation for the aging population. We also published a report on the silver economy, and our commissioner on demography currently, Commissioner Suica, has done a lot to promote silver economy in these last 2 years. And we are also opening a new partnership with member states, with Horizon Europe, called Transforming Health and Care Systems, that should start at the beginning of 23. And working on the new Horizon Europe working program, in particular relevance to the aging population and to the demographic challenge, is Destination 1, staying healthy in a rapidly changing society. And recently, in June this year, we published a technical support instrument for person-centered integrated care. This is a program managed by DG Reform and is actually directed more to politicians and to administrators of member states in order to help them and make necessary legal reforms when it comes to promote person-centered, to promote integrated care, and also to promote the reimbursement of integrated care, and also of course, innovative devices. So this instrument is going on at this moment. And further on, lastly, are the EU Care Strategy, as I mentioned before, the European Health Data Space, and the artificial intelligence testing and experimentation facility in health that is supported by Digital Europe program and aims to help accelerate the testing and validation of high TRL or solutions quickly to the market. And also the Pact for Skills, which is particularly aimed to support digital skills in health and care. Next slide, please. This would be my last point, and just go a little bit deeper into the EU Care Strategy, which was published on the 7th of September, so less than a week ago. The EU Care Strategy was, in fact, the product of work of the Commission of several services together. DG Employment, DG Connect, in particular, DG Santé and DG Just. Some parts of it are aimed particular to childcare, while the second part is aimed in particular to providing integrated care and to take and long-term care services. And you could have a look at it later on, but it does aim to provide better health and care, community-based care, to close territorial gaps, and also to roll out accessible digital solutions to provide better health and care. And with this also we are promoting a council recommendation for the council on December on long-term care in order to make sure that member states take necessary actions to promote long-term care and ensure that it's delivered to its citizens and the growing aging population. Yes, I think that with this I would end my intervention. I would like to also congratulate you for this project, because from my experience, PPI and PPC projects are particularly difficult to manage. So I imagine that it has been a long and not so straightforward journey. And yeah, I wish you a nice and interesting day today, and thank you very much for inviting me, and I'll try to follow as much as I can during the day or the other interventions. So yeah, thank you.
Thank you very much for your wishes and for your congratulations. And now, with no further ado, I pass the word to Dr. Jay Wright, and that he will explain us the relevance of addressing the evolution and the treatment of patients using or in need of an implantable pacemaker.
Thank you, Rosanna, and thank you, Irina, for such a lovely introduction. I'm a consultant cardiologist, so I will unashamedly put forward a clinical perspective on this very important issue. But I think there's a few thank yous that I need to say beforehand. First of all, thank you to the European Commission for having the courage to tackle this extremely difficult topic. Thank you to our collaborating centres, not just those in Spain, but those who set out with us from Italy and Holland. And I think it just shows the difficulty that the attrition rate of hospitals falling off this project was quite high, but the learning from it will also be enormous as a result of that. It's important that we learn not just from the successes, but from the failures as we proceed. I'd particularly like to thank our coordinating team at Aquas, our newly acquired friends, and the Innovation Agency in the UK, without whose support we would never have managed this. My internal team have educated me continually. The finance team with Mike and the procurement team with Steve Duran have opened my eyes to things that I never knew existed in the world of healthcare. As a very selfish and single-minded clinician, I only see the patient in front of me, and I now realize that the work behind the scenes is far greater than I'd ever actually understood or even considered. Finally, I'd like to thank our partners in industry who've worked tirelessly with us. And for me personally, as a very strong pro-European person, I did attend school in Paris briefly when I was 10. This has been a great honor. So, setting the scene for pacemaker patients, I have to say at the outset that pacemaker implants are only a small proportion of the implantable electronic devices that we use in cardiology. And I think it's fair to say that they are underrepresented in terms of research, in terms of the being at the forefront of delivery of home-based care, because things tend to be dominated by the ICD and CRT patients, and the devices are more expensive, shorter lasting. So there's a very big financial incentive for industry to support this. And also the ICD and CRT patients tend to be suffering from heart failure, and the biggest cost is hospital admission. So reducing those hospital admissions has been a really big incentive to introduce end-to-end care packages for those patients. But let's just consider our poor pacemaker population, because pacemakers are the commonest electronic device that we implant. Where depending on where you live in Europe and what your postcode is, the implant rate is between 500 and 1,000 devices per million population per year. The average age of a pacemaker patient is 78. They tend to have comorbidities as a result of that. And the pacemakers themselves tend to last for around 10 years. So the normal care pathway is implantation and early follow-up at 6 weeks, face-to-face, and then an annual review for about 8 years, followed by 6 monthly and 3 monthly reviews as the battery depletes and needs replacing. So these patients are old, frail, with potentially lots of comorbidities. And prior to this project, we'd always considered that they actually enjoyed coming to hospital to see us, because they received reassurance that their pacemaker was working, that we were there for them. But as we've learnt from this, our patients have taught us that in actual fact, they really do prefer being managed at home. And pacemaker patients who had to attend hospital on an annual basis were often brought in by relatives who had to take a day off work to bring them in. They might have even required an ambulance. Some were from nursing homes, so had to be accompanied by a member of staff from that nursing home. So the amount of time, effort, money, fuel, electricity now, as we have electricity-driven cars, that people expended just on bringing pacemaker patients to hospital was enormous. Because they have multimorbidities, we have the option through the pacemaker to look through alerts for other new conditions, potentially atrial fibrillation and arrhythmias. We can look at reduced activity from their motion sensors. So there is an enormous opportunity to consider in this high need population the advantages of care package delivery, of system-wide healthcare delivery at home. Now, this may not always be to the financial advantage of a hospital who gets paid per visit, whereas the care that's required to be delivered to these patients by the GP might need a very big change in the way we deliver care finance within our healthcare environment. So I think this is a particularly needy population with a particularly beneficial impact from the delivery of home-based monitoring, home-based care, more closer to home delivery and involvement of primary care physicians. And as we've seen from this, there needs to be delivery at scale. There needs, I'm very sorry, my computer's just turning something off. There we go. And we need to demonstrate cost efficacy in this population. So I think there's an enormous need that we've attempted to tackle. I think there've been some very difficult things such as procurement and demonstration of cost efficacy. But most important, we have to keep the patients at the heart of this, and their responses and feedback, their satisfaction has to be very highly weighted in the way we deliver this. Of course, when we set out, we weren't in the throes of a COVID pandemic, so we've all had to change tack completely. The COVID has provided enormous benefits to healthcare as well as enormous detriments. So I suppose in a way, in this particular project, I am grateful to COVID because it gave us the incentive to deliver at a way bigger scale than we'd ever anticipated remote pacemaker follow-up and management. And I think in view of time, I will hand on to the next speaker who will take forward our plans, having explained the need in this particular patient group. Thank you very much.
Thank you very much, Jay, for your nice word and your nice introduction regarding the rationale and importance of RITMOCORE. So let's move on. So now we have Yonita Balaga that will go through the overview of RITMOCORE PPI from the unmet needs definition to deployment of innovative services. Thank you.
Thank you very much, Rosanna. Thank you very much, Irina, for the great introduction. Thank you very much, Jay, for setting the problem and defining the need to implement action. So I'm sharing the screen. Hopefully it is seen properly now. Did you please confirm,
not yet.
Rosanna?
Yes, now yes.
Okay. So good morning, everyone. So now let's have a look at the overview of RITMOCORE PPI project and what were the tasks implemented in the preparatory part of the project, from the unmet needs definition to the deployment of the innovative services. Then that they will be tackled in the block 2. So RITMOCORE PPI is a European Commission funded project under Horizon 2020 call and started back in November 2016. So it had a total was 69 months, so quite a long project, but well worthy. So it gathered 4 hospitals, international hospitals. The first one is the Liverpool Heart and Chest Hospital in the UK, and 3 Spanish hospitals, the Hospital Santa Creu i Sant Pau in Barcelona, the Mutua Terrassa in Terrassa, Catalonia, and Bellvitge University Hospital, which is in Hospitalet, a small neighborhood close to Barcelona as well. So 4 hospitals jointly procuring, and with Hospital Sant Pau as a lead procurer. So the Sant Pau Hospital was procuring in the name of the 4 hospitals, and in order to adapt all the procurement, each of the hospitals' procurement to their local context and the specific needs, These were divided in 4 different lots, one for each hospital. Overall, the procurement budget was nearly 20 million euros. And well, they were not alone, and they were supported by 4 entities: Aquas, the Agency for Health Quality and Assessment of Catalonia, who was acting as coordinator; Valde, with great knowledge and expertise on innovation procurement; Smart Homes in Netherlands; and Innovation Agency in the UK. So with all, the consortium used the value-based procurement to transform the PACE markets services. So when we started the project, there was a clear picture that the current hospital center service model wasn't sustainable, as there were quite several limitations. There was limited available human resources. The financial resources, of course, are not endless either. And the procurement of pacemakers were based on price, with limited access to last generation devices. Given the demographic change, there is an increasing number of patients and other elderly people in our society. And it was also observed that there is a lack of coaching and training these patients. So with all, it was observed that the problem was severe, the demand was even increasing, hugely impacting in the hospital's budgets. So it was observed by the consortium that there was a need to move from a hospital center model to a patient-centered care services. So there was a need to have face-to-face visits only when clinically relevant, to provide with the most adequate therapy, personalized therapy. In case of doubt or fear, there was a need for the patients to be educated and trained in specific aspects, so they can also be empowered in their own healthcare delivery. And for the general practitioners and referring hospitals to be continuously informed about the patient's health status. So with all, RITMOCORE aimed to use the public procurement of innovation to procure innovative ICT services to improve arrhythmia's care process, moving from a pacemaker implanting hospital center service to patient-centered care service, maximizing the value for the patient. So here we can see an overview of the project. We started with some preparatory tasks, such as the needs assessment, commonly between the consortium with supporting entities specialized in the field, and of course the hospitals with really relevant expertise in the field. Then an exhaustive state-of-the-art analysis was performed in order to understand what was currently the market providing, what was the level of technology in the field. So a first set of functionalities were defined, according, of course, to each of the hospital's business cases. As a result, then we started a dialogue with the market, with the open market consultation, which led to an appropriate call for tender documents writing and launching. So we will see a little bit more about the call for tender process in the next slides, but coming back to the preparatory tasks, highlight that as a result of this common needs identifications, 5 big pillars were defined. Remote monitoring was needed, a coordinated care between the hospital, healthcare practitioners and patient was needed. Patient was needed to be activated and empowered in order to participate in the personalized arrhythmia therapy. And for this, there was a need for a change of management process in order to get to these points. So getting a little bit more in detail related to the change management, it was identified by the consortium that there was need for an e-learning platform for healthcare professionals, which contained a dashboard that enabled them to manage the change and assess the key performance indicator satisfaction. Related with the personalized arrhythmia therapy, it was highlighted that there was need for a provision of appropriate devices for each patient and adequate the device and settings proposed by RITMOCORE platform, thanks to the data from the remote monitoring. Linked to this, there was also highlighted the remote monitoring, as it would enable the detection of device malfunctions, changes in health conditions, and of course, this remote monitoring needed to be interoperable with the electronic health records. So with all, this would enable a coordinated care with pacemakers, patient information accessible for all the professionals, applicable professionals, of course, and the electronic health records would be integrated in alerts sent by remote monitoring platform. Last but not least, the need about activating the patient. So this solution, this service should also provide education messages for patients and informal caregivers, so they could coach and train them to be part of the healthcare delivery. All these 5 pillars, together with the relationship between the hospitals and contractors through a risk-sharing model based on these defined healthcare outcomes. So once these requirements were defined, we started a period of dialogue with the suppliers. So we launched the prior information notice by the end of July 2018. On October 2018, it was when we performed the dialogue with the companies. We have online questionnaires answered by specialized suppliers in the field, as well as face-to-face meetings. So with the feedback of the market, we started drafting all these risk-sharing key performance indicators and different terms that were key in order to define the call for tender documents. So it took a time to work on a specific and appropriate way to write the call for tenders. And it was on January 2020 when we finally launched the invitation to tender. It was just 2 months earlier before that the COVID-19 pandemic began. So it was planned to have the deadline by the mid-March, but given the consequences of the COVID-19 pandemic, this was afterwards delayed until May 16th. Of course, COVID-19 has affected the contract implementation, but RITMOCORE, both hospitals and contractors, got to overcome all these barriers. And finally, it was in November 2020, between November and December 2020, when contracts were eventually signed with suppliers and final awardees. So these contracts contained this new and innovative risk-sharing model. So the overall objective was to move from a model based on payment per device to a risk-sharing model based on comprehensive services, performance-based payment, and capitation fee. So as we can see in the chart, in the fixed rate for a given population, the service suppliers guarantees the provision of services for a certain level of annual activity. And when the activity exceeds or either exceeds or falls below this fluctuation margin, either the hospital or the supplier will assume the additional costs and responsibility. So in total, it was 18 payment for performance indicators that were defined and divided among the 5 pillars that were previously presented. So we would see just 3 examples. The first one, under the personalized therapy, one indicator that was defined was the rate of pacemakers implantation indication according to current European clinical practice guidelines, in order to ensure that the pacemakers were respecting the standards to be considered European clinical practice guidelines. Second example would be to ensure that the major complication at 90 days after the implantation, in order to measure this and also take this fact into account. So these major complications after 90 days were also measured, and this would have an impact in the payment for performance indicators. And the third one, this is related with the remote monitoring, would be the detection of patients with new onset atrial fibrillation within 1 month after the debut. These are just 3 examples, but if interested, you have access to the whole call for tender documents under the contracting platform, and it's also available in the project website. So I will not make any spoiler about the results and the contract implementation. This would be presented in the block 2 by the contractors, the suppliers, and the hospitals. But we have presented the results, and in several congresses and in several workshops. And as a result of this contract implementation, we got the chance to participate in relevant forums from, specialized in cardiology and other kind of forums. For example, there was a cardiovascular disease event in Granada this year. Most of them have taken place in the last year, once the results are available. Also, the ex-patient Barcelona Congress. We had an oral presentation in the European Health Management Association in Brussels, was in June 2022. And we also presented RITMOCORE in the MedTech Forum in May in Barcelona. As a result of the perform activities, we got the chance to also leverage and expand on the value-based concept. The RITMOCORE project results were presented in Global Innovation Hub for improving value in health, also the European Active Healthy Aging Week. And we have written some scientific papers, such as in the management in healthcare, and also contributed in the handbook for pioneers in the EIT Health implementing value-based healthcare in Europe. So as a result of all the learnings during all these years, we have compiled the views from hospitals, participating hospitals, from the consortium, the supporting entities, also from the suppliers, not just the ones participating in the contract implementation, but also from the ones that were participating in the market consultation and might have presented an offer, an unawarded offer. So gathering the feedback from all these kind of suppliers was really relevant and provided really good learnings and constructive learnings for the model that was implemented in RITMOCORE. In the same way, we gathered feedback from really relevant clusters such as MedTech Europe or FENIN in Spain. These all learnings are compiled in the RITMOCORE handbook guidelines that will be available in the website in short. In the same way, we gathered the views from relevant stakeholders such as the hospitals and buyers participating in RITMOCORE, patients' perspectives, payers and policymakers. Fortunately, all of them are participating in today's event, either in the block 2 or in the block 3 in the roundtable, so we will gather their views. And the policy brief is already available in project website. With all, we got to achieve relevant impacts per targeted stakeholders. For patients, they are now able to have a remote and increased frequency of monitoring, reducing the travel burdens. Now we are capable to early identify the problems, and the patients themselves are more empowered than they were in the past. Relevant outcomes as well for the general practitioners, as they have now reduced, or they have seen reduction of routine visits without clinical value for patients. Now they have unified platforms with data collection and analysis, technical support from manufacturers, as they are now collaborating daily with them. And of course, in the same way as in the patients, they have been empowered to make their own decisions. So in addition, the hospital themselves and the healthcare organization have seen relevant benefits, most of them as well, not just for the ones that were presented, but also economic impact with RITMOCORE PPI model. Now they are aware of what is the yearly budget, and they have seen reduced costs in several ways, such as in visits, ambulance, emergencies. They have now less stock and maintenance, and the fixed rate per population. With all, as observed in the previous slides, the complications are shared with the suppliers. To the industry, they have moved from low price competition to value-based competition, and they are now partnered with hospitals. So the collaboration is much closer than it was in the past. And they, in the same way, they are now cooperating between the brands themselves. So the innovation ecosystem has been reinforced as well. And just as an overall outcomes for the health system, the targeted population has now better health status. There's a long-term increased sustainability, a more efficient use of public resources, and an agile deployment of advanced digital services. So just to conclude, the last slide, the overall general an overview of the achieved impacts. RITMOCORE PPI has consolidated a model of care which, using public procurement of innovation as a vehicle, guarantees the patient-centered care. In the same way, RITMOCORE has created an attractive pool of knowledge which is now open to other procurement organizations or innovation ecosystem partners to continue enhancing and optimizing the developed and adopted solutions. The project has had relevant excellence recognitions and awards, such as the awarded for operational excellence in healthcare management by Novartis, and ultimately the project laid the foundations of a future value based in a risk-sharing model with the industry partners. So this would be it. Thanks very much for your attention, and I think that now this closes the block 1, the opening session. So I don't know, Rosanna, if you want to.
Thank you very much, for your nice presentation and your nice overview. And now, yes, let's move forward towards block 2, resulting in innovative services. We will have a small change in the agenda, but at the end it will be the same. That is, we are now having José Luis Cerezuela from Biotronic Spain explaining how was the deployment of these innovative services in both hospitals, Hospital San Pau and Belvice University Hospital. And then we will have later on Dr. Xavier Vignolas from Hospital San Pau explaining his experience in RITMOCORE from healthcare provision and healthcare professional. And then from Hospital San Pau, and then we will have Dr. Ignacio Anguera explaining again his experience from healthcare provider and healthcare professional from Belvice University Hospital. Thank you. So please, José Luis Cerezuela.
Okay, I will share my screen now. Let me see if I can give you. If you see my full screen, and once you see that, just let me know and I will start.
We can see the present. Okay, no, we can see the presentation with the small screen, the two, within your notes. Not the full presentation.
So let me stop sharing, try to.
Now it's
Oh,
good.
it's different. Okay. Yeah, I think
Yes.
I clicked on the wrong window.
Thank
Okay,
you.
thank you. Thank you. I will try to stick to the time because I know this is a very tight schedule today and very interesting. So I will go through the agenda that was proposed by the organizers, which is basically what you can see now. It's a presentation of the company. It's Biotronic as the company that was awarded. But we also Madrija, which is the subcontractor company for the IT services. Then the rationale of buying to RITMOCORE PPI and how we saw that from the industry point of view. The contract experience itself. So it will be a very short story from the offer submission to contract awarding and the execution. Then I will make also some highlights on the presentation of innovative contracts and services that derive from the RITMOCORE experience having introduced in our portfolio or in other hospitals. And then the end will come with the major achievements and lessons learned from our perspective as a company. So Biotronic and Madrija. Biotronic, well, we are one of the 5 competitors in the cardiac rhythm management companies. Since the 60s, so I will go deep into that later on, and then I'll do the same with Madrija, which is a relatively new company. It was founded in 2015, and we entered into relationships with them in 2017. So Biotronic is a core business company. So as a difference with other companies in the market like Medtronic or Boston Scientific or Abbott now, where I've been working in the past, this is a core business company for good and for bad things. So in our case, we're very focused on these 3 lines: cardiac rhythm management, which is implantable devices to correct rhythm disturbances, vascular intervention, both coronary and peripheral, and electrophysiology, which is non-implantable devices, but it's a way of doing ablation diagnostic, ablation of arrhythmias, complex arrhythmias. Okay, The company was founded in 1963. So on that decade, it was only pacemakers. It was the first German pacemaker was built in Berlin. And then the next decades, over the next decades, there was some international growth of the company and changes in the internal structure. It was not until the decade of the 90s that ICDs and were introduced, and the cardiac resynchronization therapy and the expansion until the three product lines that we have today. In the first decade of the actual century, there was something that was a pioneer on this field, which is the home monitoring. There was the first company in introducing the home monitoring in the market. It happened in 2001. And then from that, and also with some interesting algorithms like CLS and other developments, and from then on the 2011 decade, 2010 decade, then the company started to develop more lines in other divisions. So what's coming next in the future? Probably we will enter into neurostimulation business in this decade, and that's also an expansion that the company will have. So just a couple of highlights on how different this company is in terms of high tech and production. We only manufacture in high tech and high cost countries. So the headquarters, Berlin, Germany. It's a company that only manufactures in Germany and not in any other place in Eastern Europe or wherever. There's also a factory in Switzerland. There's another factory in the United States, in Portland, and there's another manufacturing site in Singapore. So there's nothing outside of this region. So this is something which is interesting because in the actual times, we are having a very good performance in components provision and so on. So disruption of stocks are fairly under control in this way. So we are happy to say that and very proud of it. So Madrija is a consulting company that was created in May 2015. The people working there were coming from another regional health systems in the country. They created their own company, and we entered into contact with them in 2017, where we started to develop some interesting features and systems that led us to start the expansion to other areas, like in this case, RITMOCORE. Just to give an overview, they have one main office in Toledo. In parallel, when we entered in with a subsidiary in Barcelona, and in parallel, when we started our conversations with them, they also started operations in Switzerland, where they have another office in the Zurich area. No? So there are 47 employees, and most of them are computer engineers. It's a pure IT company. They've been growing their volume of the company year after year since then. And they're basically working on the IT solutions for the health system. So they started with their module for interventional cardiology. That was their start, and then with the support of Biotronic, they started to develop the arrhythmia modules and so on. So that's the profile of the companies. I will go to the next point. So what was the rationale of bidding to RITMOCORE, to this new PPI concept in this country at that time, and taking a look with some perspective? As Jon said, this started in 2016, and there were many conversations, many things coming on until 2020 that it was a reality. At that time, there was only one experience in Hospital São Paulo. That was the first edition of Stop and Go. And at that time, when we heard about RITMOCORE and our conversations with the hospitals, we were not sure of how it could evolve. Now, in 21-22, the situation is different. There have been any other projects, and not only in Catalonia. As you can see, there's one project that has been awarded a couple of months ago in Cordoba, in the south of Spain. So this is in something which is growing. How long is it going to grow? How are things going? We don't know. Going to go? I don't know. I have no idea, but I can tell you there are many hospitals asking outside of Catalonia, outside of the region where all this started in our country. This is creating extreme interest on this new way of procurement, and making questions how things have been done, how to create these type of things. Can you give us more overviews? Can we contact the hospitals? I can tell you it's a huge activity around this. And making a very rough calculation, it's between 6 and 8% of the total volume of the CRM and electrophysiology markets. Both together are less than 3 million euros in this country. So the amount per year is around close to 18 million euros. So it's attractive. And I think it's going to be the starting point for a major change, which is yet to come. So based on that, we were thinking, do we have a strategy? Can we build a robust offer? How can we develop a solid service value proposition around home monitoring and other services, remote services with external vendors, which is also interesting. It is something that is changed. Well, the traditional approach is what all companies can do, is selling devices, giving some basic service, especially in implants and patients follow-ups and some remote monitoring and trainings, and yeah, but there's nothing organized. It's most of the time all this is done on demand, and there was nothing vertebrated. I would say there's no any spinal cord. No? Then we started to assess opportunities. We have been working on this before, so we understood that this could be an opportunity to change many things. We also evaluated risks, because clearly Medtronic was probably the company that had some advantage on this field. And we were not afraid. We basically decided that even if we can foresee that there might be some risk in the business, if Medtronic is winning again or whatever in the financial model, we decided to go on. We decided to go on, and we had to overcome some difficulties. Clearly, but I mean, we did not reinvent the wheel. It's not necessary, as you know. This is a real picture of how cargo ships are now trying to save fuel. They are using kite surfs, and then these sails they existed centuries ago. That's how sailing was before engines existed. So nobody has reinvented the wheel. They have simply taken and put together and marinate, like food and wine, existing solutions to transport goods and wherever. So the only thing we have to do is to change our mind and put information systems in the middle as a central core of the rest of the developments, to be able to fulfill the pillars that were mentioned before, and try to create and tell a story that demonstrated that we understood what the procurers wanted. And that's what we did. We created a task force specifically from people from my team were dedicated to this new task. And in parallel, we kept working with other companies that we had already done before. I mean, we were working on this before RITMOCORE. We kept that because you never know what can result in the future when these companies are growing and offering new solutions, because these contracts have 5-6 years length. So you need to have options in your portfolio. No? And then the most difficult barrier was to overcome all the difficulties from the financial point of view, because we need to get approvals from the business unit, our vice presidency in Switzerland, in Midwest region, and also approval from finance. And that was not a numbers task. It was a matter of motivation. I think that we showed motivation to our central structures in Switzerland, and it was not easy. I can tell you, it was not easy. We had to go through a lot of questions, a lot of discussions, and that's why we at the end presented an offer to lot 2 and lot 4. We could not be to lot number 3. So just to give you an overview in numbers, on those months that we were preparing the offer, at least in my computer, and this is an example from my computer, I have 961 RITMOCORE documents. Around a third of it are directly related to the offer. So there was a lot of work behind. But despite of the fact that the deadline was extended, as Jon has commented, it was March and then it was extended until May, we did not modify anything, and we kept our first proposal. All the effort that was done and how we told the story of what we could do, we decided, wow, that's our best offer. That's the best thing we can do. And we kept it as it is today. So once the contract was awarded, we had to present it physically to both hospitals, to São Paulo and Belviche, in different dates. There were long presentations, 2-3 hours. There are many questions, and where we understood we need to explain that our offer was basically not putting catalogs together in a big file with many things. No. There was, as I told before, in spinal cord, there was a vertebration, and I think that we understood the objectives and targets of the procurers, and we were aligned. No? In parallel, we were already doing an internal restructuring and change in resources assignment, which, by the way, has been demonstrated that it's never enough. But we can discuss it afterwards. And once awarded, another key point was to start negotiating with other companies, because we needed to guarantee the product continuity in the normal activity of the arrhythmia units on both hospitals. So that was also a very good experience. So the execution, well, something that we have realized is that the initial phases usually take longer than expected, and it's due to multiple reasons. As the hospitals, when they will present the results, I think they will say something which is pretty similar. We need more time and more work to integrate the different stakeholders in the hospitals and in the companies to speed up this type of processes. This is lesson from year one. There's another point which has to do with how the governing model, how is it organized, how to work. So working groups are very effective, and also the technical board for contract monitoring. They have for frequent meetings. I think that this is very useful to monitor how things are evolving. And in year 2, year 3, year 4, we'll go at different speed. No? That's clear. Then it's also critical the coordination among all involved in these tenders in order to anticipate scenarios and in order to monitor KPIs in advance, stock disruptions, new products in the market, and how they can be introduced to the hospitals according to the technical specifications of the tender, because it's also defined in percentages and so on. So it's also it has been also, and it's being also a very good experience. So if we go to the part of what things have been created that did not exist at this extent, and we've been able to introduce, the first example is the Center for the Remote Support Monitoring Support that was also used for Adele contract, which is another PPI only in Hospital of Belviche. So that was the first one, and now we are developing a pilot for other regions. We are working with 4 of the 5 companies. And actually, it's 1,000. These numbers are coming from mid-August. 1,177 patients. Those of them directly related to RITMOCORE is 960. Again, mid-August. So it was organized, customized for the 2 hospitals, São Paulo and Belviche. The basic tasks on the right are common, but the way of filtering alerts and working with the hospital is slightly different. So that's why there are people behind. We have a person coordinating it with the different levels of work that we're actually thinking in readapting for the future. The second thing is the Enigma, tailored for other hospitals. We started the story before RITMOCORE with the 2 first, Puerta de Hierro in Madrid, in the Majadahonda village close to Madrid, and in Burgos. We already had the experience there, and then RITMOCORE entered, and as of RITMOCORE, other hospitals, you may see some on the list, there are more, but some are in different stages. Jean-Baptiste is already under deployment, and Tracy Pujol is finalizing the administrative process, and Valencia and Alicante, they are also in the same stage. And we're working in other hospitals also to work with this. This experience has been inspiring for other hospitals. That's a good thing. The third one, and this is something that Berlin, clinical department in Berlin, so the part of the company that is in charge of creating clinical trials and managing clinical trials, is going to adopt the Enigma Hub, which is it's not the acronym of Hospital Universitario of Belviche. It's the English word for something that centralizes all this information, that will speed up all the way that a clinical trial is today carried out. So it's very important because it will help to speed up how things are managed, and of course it will revert into the RITMOCORE hospitals and many others. So if we go, just I'm finalizing my presentation. If we go to the major achievements, well, some of them can be highlighted. Is the full portfolio. I think that there has been no disruption on all the product supply chain from all manufacturers. As I said since the beginning, we had to negotiate with other manufacturers to overcome some difficulties between the moment that the awarding was published and the contract was signed. There was some time gap in the middle where people were not so sure if we could negotiate prices. I can tell you that the attitude of the companies in general has been very collaborative, and that's part of the success of this. So the Center for Support of Remote Monitoring is also another achievement. I think it was established in the way it has been today, and customized for the 2 hospitals. It was established in record time. It's close to 1,000 patients, actively following up in the first year of operation. So something which is, because patient has been mentioned by Ion and other presenters, the patient empowerment, which is also one of the pillars of the tenders, the didactic materials, the training for individuals and families. It has been developed also in record time with a lot of implication of the different departments in the hospitals. So and that's a good also a good point. At our internal level, now it has been also interesting because we have been able to face a new model of relationship within the area team in Catalonia, because we need to transform the local team and put people that were used to do one thing to do a completely different thing, and they did it in record time. I'm very proud of my team and how they have been able to work together and how they are working together nowadays. So also internally, other divisions in the company saw this something which is probably in the future, in the cloud and whatever. No, it's a reality. It's now a reality, and that has forced them to change their mind and also talk to their customers and try to find opportunities to sell products and services and change the way that the market is evolving actually. And it's also an important point, the employment opportunity, the social responsibility, because there are headcounts that have been incorporated only to deal with this. It's not only the transformation of the structure, but also we need to incorporate more people that are doing specifically this type of tasks. There are headcounts that did not exist before RITMOCORE. And then another good point is the parallel relationship that has been consolidated today by the financial and administrative departments for both the company and the hospitals. And this is something that did not exist at this extent so far. So that's my last slide. The lessons learned is a challenging experience, and it has been mentioned that partnership is critical. Of course, it's critical. If we need to work in a different way, we need to abandon the concept of buyer-supplier model. I think that we need to work in another level of relationship. I think that RITMOCORE is changing this, and I'm happy with this. Another critical point is the profitability, because the long term of all these tenders that we have seen in one of the previous slides, that we have seen that there's a lot of interest in the market, and there's a lot of interest in other competitors, because competitors that did not want to enter into a joint venture for this or other projects, and I can tell you the story, could tell the story behind of this, now are coming to us and, oh, could we do something together? Yes, of course, I'm open to negotiate. But it's also important to work with the procurers in understanding profitability in the long term and trying to build this type of tenders much more in advance, because then the market, if we don't take care of this and analyze from this other perspective, it's a pity. There might be scenarios where other hospitals or other regions would not enter if this is not worked properly. So my last point is an excellent opportunity for technical innovation for patients. So I think that the future is that the patients will know more and more about these new solutions, these new therapies, how they are managed. And the visibility is bigger. I mean, Twitter, LinkedIn, whatever. well, it's tremendous. It's tremendous. So many thanks. That's our view on this.
Thank you very much, José Luis, for your great presentation, gathering your experiences, your reflections, your conclusions, and as well as the lessons learned, which are key for both the procurers and suppliers in the future to be able to either replicate, escalate, or to make use of the model used in RITMOCORE. So thank you, José Luis.
Yeah, okay, you're welcome.
So moving to the next part, now it's turn to gather hospital's view. So now we have Dr. Xavier Viñolas, cardiologist in the Sant Pau Hospital, who will speak about their experience in the contract implementation of RITMOCORE PPI model. So Xavier, I can see you.
Are you hearing me? Only a moment.
Perfectly.
I'm not able to share my screen. If you have my presentation. If not, I need to change a little bit.
Let me check.
Don't worry. Moment.
I have them ready. If I can.
Oh, I already have it.
Perfect.
It's okay for you.
Yes, we can see them, not in presentation mode, but we can see the slide.
Well, it's a PPT. Not we will. Better now?
Yeah, perfect.
Okay. Okay. Thank you very much for inviting us to present our experience and our thoughts and what we think about the future, the present and the future of this kind of projects. Most of a lot of things has already been explained before by Jon and especially also by Biotronic. And I can begin with the end of my presentation after the presentation of José Luis Cerezuela. The main goal of these projects has already been achieved because you have seen 10 or 15 minutes of a presentation of a technical company selling pacemakers, not speaking about nothing regarding the technical things of pacemakers, nothing about my device is better than the other, nothing regarding only innovations specifically in the device and all these things. No? You have seen a company selling devices speaking how we deliver better his technology to the patient. And I think this is one of the main goals of all these projects, changing the paradigm of not selling a single device, but selling the device plus all what you need to make this device work better for the patient. Regarding ourselves, only two slides about our hospital. Our hospital is one of the 5 university hospitals in Barcelona. It's a mid-sized hospital with 500 beds. We have we have in charge 400,000 inhabitants of Barcelona, plus another 500,000 or 1 million inhabitants from community hospitals. So we act as a community hospital in part and also as a tertiary hospital for the advanced technologies. This is the size of our hospital. It's what we call in Spain a mid-size hospital. Regarding our experience in value-based healthcare, it's true that if we see at the right, that we have already begun with this kind of projects several years ago. The first project was the Stop and Go project. This is a project focuses on ACDs, implantable cardioverter defibrillators. These are similar to the pacemaker, but a little bit more sophisticated with less patients, higher cost, and more. It's more important to have a very close follow-up of these patients. We have been awarded by the European Commission in a value-based healthcare in 2015. We have improved the project, and with RITMOCORE, more sophisticated regarding especially the goals and the objectives to achieve. And this was published, you have seen, in 220. What is important for me, and I think this is one of the message we want to share, that nowadays this project has finished in 2021, and we have this, what we call a stop and go 2 of the project. What's the difference between this one and this one? It's a little bit more sophisticated regarding the parameters we measure, but especially in this project, we have not the support of the European Commission. So there's no additional money. So this means that the administration of the hospital thinks that this kind of projects are interesting for the patient, for the hospital, and for the cardiological department. Well, this is only to explain a little bit more. Only to compare a little bit our first project and the project of the RITMOCORE. They are very similar. These are also implantable devices, the ECDs, these are pacemakers. The difference is the numbers. Here we have 150 patients per year. Here we have more or less 400 patients per year. These are 60 years old in mean age. Here it's 75 to 80 years old mean age. More or less the things are similar. You have already heard about the pillars. The personality therapy is on in the 2 projects. The remote monitoring is on in the 2 projects. Obviously, a little bit more sophisticated in this part. What we have is that in this RITMOCORE project, we have incorporated a coordinated care. That we try to begin to work in a network with our general practitioners and our community hospitals. So thinking about this idea that value-based doesn't means not only working in a value-based in your hospital, you need to expand this through all the integrated care system where the patient is coming. And especially the patient empowerment. This means all the projects with nurses, with APPs, and all this kind of thing is much more sophisticated. The goal was to use 2 things, to use the way we pay to the company and the remote monitoring to make the change of the patient journey. This means before all these projects, the patient came to the hospital 1 week after the implantation, 1 month after the implantation, 6 months after the implantation, and afterwards each 3 to 6 months to have a visit in the hospital. We want to change this to 1 visit 1 week, after 1 month, and afterwards main of the visits of the pacemaker should be through a remote monitoring. So we use the remote monitoring, and you use the way we buy all the system to change this. And in fact, if we have done this, we have had a big reduction in the hospital visits. The reduction in the hospital visits is not per se a goal of these projects, because in fact, what is important is to reduce the hospital visits without reducing or without increasing the complication of the patient. Because in fact, at the end, what you need is to maintain a high quality level. One of the other important results is that using this kind of projects where you have some goals you need to achieve as a team with a company that wins the tender, is that we have more than 90% of our patients are in what we call the RITMOCORE program. This means are in remote monitoring. This is not so frequent if you see the statistics in our country. or in Europe, where in some places less than 10% of the patients are in remote monitoring. It's true that this has increased after the pandemic, but we are still, most of the hospitals are still very, very far away of this 90%. And why we did this? It's not only because we want to do better with our patients, but in fact, we had a problem. We had a problem in our hospital and we needed to solve this problem. And the problem we had in our hospital is that the process of the patient journey of the pacemaker patient was not correctly organized. We have several interventional teams. We didn't have a good response to implant the patients coming to the emergency room. So sometimes the patient was more than 1 or 2 days waiting. We didn't have an IT system to measure correctly our results, and we didn't have a very good system information connected to our electronic medical record. So at the end, this means that a lot of these old patients came to the hospital much more times that should be good for them, with a family overload, with healthcare teams overload. So it's not and with a lot of what we call low value work. No patients coming only for a routine checkout with anything more to do. What this has already been explained extensively by John and also by Jose Luis from Biotronic. It's true that when you begin with one of these projects, it's a lot of work. No, it's a lot of work because you need a lot of preparation. And regarding the preparation, it's you need a very good collaboration between the contractors of the hospital and the clinicians, because you need to put together what legally is possible with what clinically is necessary. And also because the clinicians need to define something that it's not so evident sometimes. You need to define very well the KPIs, the KPIs, and some of them are of quality, but some of them needs to be with activity. You have seen this slide with the fluctuation and the resharing. You need to be sure that what kind or what volume of activity will you will be buying. No? And regarding the quality indicators, you need to be sure that the quality indicators you are giving to the company should be hard, easy to measure, and affordable. So you need to know that they are possible to be done. During the procurement for the clinicians, it's not easy, this phase, because we are not, and we should not be, expert in procurement. So for us, sometimes it's difficult to understand the work of the people making this procurement. So it's very, very important to work in very, very close together with the teams of procurement with an open-minded view. They need to be open-minded in order to understand your needs, and you need to be open-minded to understand that some things are possible and some other things are not legal in your country, so you cannot ask this kind of. During the implementation, the lessons we have learned is that sometimes things that you, or some aspects you think that are very easy are not so easy. For example, when you, some IT company says, it's quite easy, for us it's very easy to implement the electronic medical record interface with the system of your hospital, and you think, okay, they know very well. at the end, it takes a lot of time. And it's only an example, it takes a lot of time, not because it's technically difficult, because when you manage an electronic or medical record of a hospital, sometimes it's not only the hospital, it's a hospital, the primary care, all the whole system. You need it's a very difficult decision system where each change needs to be supported by a lot of layers. So it's not a matter of a decision and like this in 1 month, it's done. And during the implementation, it's extremely important to work very close together, the clinicians with the company that is doing the service. Because sometimes not everything can be extremely detailed in the contract. Something new appears, you need to find solutions for this kind of new thing. For example, a very simple thing, but when you say we need to a reduction of the visits to the hospital, sometimes it's not so easy to define if a patient has come to the hospital for a visit of a pacemaker or for another thing. So we need to define very strictly what is each device. What are the other lessons we have learned? And I think it's important for everyone that begins with this kind of projects. When you are young, you want to begin everything at the first time, and you want everything the first year. And at the end, you realize that this is not possible. So you need someone, and here we have Katerina that has helped us a lot in this, to say, okay, we can do every aspect of the project will be done, but we need to put in a timeline, and in an organized timeline, in a way where things can be done. So at the beginning, it's kickoff, the government set off, the organizational change of the hospital. We have decided to begin since the beginning the remote monitoring and working in this personalized therapy. This is very simple. This is having the best pacemaker of all the companies for the patient, a good selection. And we decided to postpone at least 1 year all the patient empowerment tools, all the these devices or the APPs connecting to the patient and the protocols, because we think that this was not crucial for the to have this at the beginning of the project. So having a timeline, okay? These are a summary of the quality KPIs. We have summaries in these pillars. This is the activity we have done. You see that during 2021, it's the first year we have had less pacemakers than before. This is because of the pandemic, that a lot of old patients in our region has died. So it's the first year we have decreased a little bit. These are the major achievements of a clinical point of view. We have reduced the visits without impacting the clinical results, okay? So we have a very, very good clinical result. And this is the way we control the activity we have and all the KPIs we are doing. And the last lesson, I think this is the last lesson, is that this kind of projects cannot be from up to down. These are bottom-up projects. You need to have a clinical problem. You need to speak with the clinicians. They need to explain what is their problem and their possible solutions, and it's the only way. And the other learn is that value-based is not for short-term. For short-term saving, it's much better to buy in with low prices. But obviously, I am completely sure that it's much better for long-term sustainability. Thank you.
Thank you very much, Dr. Xavier, for your great presentation showcasing the experiences of São Paulo. So now it's time to move forward, and it's the Belviche University Hospital by Dr. Ignacio Anguera, who will present their experience with Biotronic Spain.
Well, hello and good morning to everyone. I will explain which is the Belviche University Hospital experience in RITMOCORE. I fully support what has said Dr. Viñolas, that it has been a very exciting, promising experience, but also very difficult and tough to set up everything, because there is an important resistance to change, and we have had to work very tough, very difficult moments for finally achieve, I think, very excellent results, as you will see. Well, our hospital is a 50-year-old hospital located in the city of Hospitalet de Llobregat. It belongs to the Catalan Health Institute, which is a public institution providing services to primary care as well to hospitals throughout Catalonia. The Belviche University Hospital is one of the only 5 hospitals in Catalonia certified as tertiary referral center, and it's also the community hospital for more than 300,000 people in the area, and serves as a reference center for more than 2 million people in the southern metropolitan area of Catalonia. We have 8 community hospitals that are referring arrhythmia patients to us, listed on the slide, but also we have a network of primary care centers. We have a total of 60 primary care centers that are referring patients with arrhythmia to us. And what about the cardiology department? The cardiology department is one of the 2 departments in the Heart Diseases Institute, also with the cardiothoracic surgery. This Heart Diseases Institute has 100 dedicated beds for cardiology care, and including coronary care unit and semi-intensive care. And we perform all kinds of cardiothoracic procedures, like heart transplant, coronary and valvular interventions, both surgically and percutaneously. And what about the arrhythmia unit? We have a program of percutaneous ablations. We perform 450 percutaneous ablations covering all substrates. We also do 150 electrophysiologic diagnostic studies, implantations of 200 ICDs per year, including 80 devices for CRT, for rest synchronization, and in-office and remote monitoring of ICDs. We have around 1,000 patients that are being controlled at present remotely. And we have also a pacemaker program. We implant around 700 pacemakers per year, including generator replacements. And we have more than 4,500 outpatient pacemaker device checks per year. Well, what was the rationale for joining the RITMOCORE PPI? Well, the Catalan Institute of Health has interest in these more advanced modes of management in the public procurement of innovation solutions. We are very interested in these new models of purchasing. We have interest in service contracts in purchasing services rather than the old product contracts. The clinicians are also interested in more integrated models of care, integrating our unit with the community hospitals and with primary care. And there is also interest in changing the processes of chronic care. We were also very interested in implementation of a universal program of remote monitoring of pacemakers, and to reduce the face-to-face visits with low value added profile, and to gain all the possibilities that are offering to us this remote monitoring of pacemakers. We wanted to take advantage of pacemaker functionalities that are lost and do not reach the GP or do not reach the patient. And thanks to the remote monitoring of pacemakers, we are able to gain a lot of information from these devices and to transfer all this information into clinical decisions to our patients. As an example of the clinical usefulness of remote monitoring of pacemakers, I have made this slide to summary all the potential that has a pacemaker that is remotely monitored to offer to us. And we are able to detect indicators of potential clinical instability that are very important. With respect to the device, we can detect any potential device dysfunction. We can monitor the status of the battery and detect an unexpected battery depletion and schedule a replacement of the battery for these unexpected depletions. But also we can detect episodes of atrial fibrillation. And atrial fibrillation is a very important disease. Atrial fibrillation promotes the formation of clots inside the heart chambers. And these clots, these thrombi can dislodge and can travel through the circulatory system and produce a peripheral embolism and finally a disabling stroke. So with this early detection of atrial fibrillation, we can prevent strokes, and this is a very important message. But there are also other clinical biomarkers that we can follow and detect in the pacemakers, such as sleep apnea, changes in thoracic impedance, detection of episodes of rapid ventricular activity, detection of fast and sustained sinus tachycardia, or detection of fixed slow heart rate. All these are surrogates or clinical events that are telling us that the patient is deteriorating, the patient is going to decompensate in the following weeks, or the patient has some other comorbidities apart from the rhythm disturbance that led to the implantation of the pacemaker. So there is an important potential or capabilities of these pacemakers if we are able to manage all the information that is available. And this represents a clear improvement in healthcare quality. Well, for the final service description in our hospital, I have to say that we have had a tough task to align all the stakeholders of the process. It has not been easy. For one side, we had the bidder, Biotronic, the hospital, with essential contributors like the general manager, the support of the director of the hospital, of the financial department, the IT department, the procurement office, and the communication department. So all of them supported us, but even with the support, it has been easy and has been tough to deploy and run the project. We have also the health staff committed with no doubt to the project, all physicians and nurses and also personnel from the administrative department, and finally patients who have been very happy to participate in this project. I will give you a detailed summary of the service description. With regard to personalized therapy, the awardee offered 3 different complete portfolios of pacemakers of 3 different brands, also technical assistance when needed, and also special devices were offered in a 4th portfolio for those very special patients that had very special needs that were not covered by the main 3 portfolios. With respect to change management, also a very important aspect, we had to migrate the database of the arrhythmia unit to the new technological solution. We had the deployment of the Enigma solution. Enigma is a technological solution offered by Madrija as José Luis Cerezuela commented. We had to integrate this new technological solution with the hospital information system. That was very easy when it was explained, but very difficult when we had to do it because there were many, many difficulties. And we established the program of remote control. With respect to activity, we have implanted more than 1,000 pacemakers during the contract so far, that is during the year 2021 and up till now. And we have started the program of remote control. Start of this monitoring of all patients undergoing the program, incorporation of all pacemaker brands, not only those from Biotronic, the awardee, but from Medtronic, from Boston, from all the brands that have been offered to us. Monitor delivery and patient education has been also an important step that is also taken by our nurses. The remote monitoring program consisted initially in the creation of this support center that is filtering all the alerts that are generated by the devices. We have more than 1,000 monitored patients, including both the new pacemakers and also some of the previously implanted pacemakers that have been incorporated in this remote monitoring program. We have had more than 1,000 transmissions, and among them, 130 relevant alerts that triggered medical or technical assistance. And 50 of them have been episodes of atrial fibrillation. And as I said previously, atrial fibrillation is a very important event detected in the devices that can lead to the prevention of stroke. And that is a very important message that I want to give, that many of the alerts have been AFib, and we have put into anticoagulation many of our pacemaker patients. We also had to establish coordination protocols between our nurses and the staff from the support center, establishing protocols of communication, either by phone, by SMS, by email, to be fully coordinated and to have all the information quickly and not having delays between the transmission and the clinical decision for the patient. And also this support center was integrated in Enigma, and also this was also difficult or was complicated to fully establish. With respect to coordinated care, we had to design and create workflows to contact with our referrals on the community hospitals. We accomplished a primary healthcare direct citation. That means that once the patient has an clinical alert, we have achieved with this coordination care that the patient has a direct citation with her primary GP to review this non-device related clinical alert. And we have had also a program for interconsultation between nurses from the hospital and nurses from the primary health care, and also protocols for training and for education of the nurses. So as you can see, a lot of work with coordination. And finally, patient empowerment, the last pillar, a very important pillar, and is one of the pillars that the people involved in the protocol are more satisfied, because it's really one of the biggest things that have changed in all the care pathway of patients with pacemakers. We have had to educate patient and the families, and we designed a patient APP. This APP is almost ready, is almost finished, and will be downloadable very, very soon. And I will give you an example of what the patient can find in this app. We have done some videos explaining to the patient what is the remote monitoring, what is the pacemaker implantation procedure, etc., to help the patient diminish the stress of the intervention, and to educate the patient and what will happen to him when he will be implanted the pacemaker, and later on with the remote monitoring of the device. Also, we have designed a pacemaker ID card similar to what have patients with ICDs. Previously, pacemaker patients had a very old-fashioned ID card, but now they have a new one that looks very similar to the ICD card. This is an example of protocols of remote monitoring and how to manage alerts in patients included in this remote monitoring program. This is another figure of how to react for any or program the devices, any of the devices, or what to do with remote monitoring or with alerts, or how to manage the automatic capture control, etc. And lastly, what to do in cases of an alert of AFib. If the AFib is less than 6 minutes, or if it's between 6 minutes and 6 hours, or longer than 6 hours, we have protocols recommending which level of communication with the hospital of the general practitioner, or if to start or not start anticoagulation, etc. So all these are the protocols that have been made up and are helping us managing all these patients. This is an example of how it looks, this APP. On the left side, you can see the front page of this APP that is saying hello to the patient. The patient can see when was the last remote transmission, when was the last face-to-face visit, and many icons with many answers to questions that the patient may have regarding the ID of the pacemaker, the manufacturer of the device, manufacturer of the electrode, one icon of frequently asked questions, etc. Here in the center, you can see how it looks, the pacemaker ID, just equal how of the patients with an ICD. In the bottom part, the characteristics of the device, and on the right side, the compatibility with MRI. Nowadays, MRI is a very important diagnostic tool, and many of the patients with pacemaker will undergo MRI at least one time in life. So this is important information that patients should know, that if this device is compatible or not, and this is included as valuable information on the APP. With respect to the main KPIs and activity index, we have accomplished a very satisfactory rates of pacemaker implantation and pacemaker replacement indices, very high, close to 100%. Not in all types of pacemakers. We have to differentiate single chamber, dual chamber, and leadless pacemakers. We have different rates of activity index, but in general, we are very satisfied with that. And we also are very satisfied with the quality indicators according to all the 4 pillars. In this slide, you can see only 2 pillars, but as an example, the personalized therapy and the remote monitoring, but also in patient empowerment and the coordinated care, we had a very high numbers and achieved 100% of the quality indicators. So that is again something to be proud of. And what are the major achievements of this project? We were able to implement the concept of risk sharing in the real world. That is very important, because current purchasing contracts do not require to measure health results, do not measure success rates of interventions, do not measure mortality associated to procedures, do not measure infections, etc. Currently, quality of health is measured in terms of quantity, and that is a severe limitation of the quality of health in normal purchasing contracts. RITMOCORE represents a real change of the model. For the first time, the service providers is committed with activity results and with clinical results. All stakeholders, hospital and service providers, are committed with the results, and providers are paid for that. And this is new, this new payment that has been established in these new models of these service contracts. Therapy for bradyarrhythmic disturbances could be implemented, offering to the patient up-to-date technology with high level of patient and staff satisfaction. And we have achieved a real change in the care pathway of patients with pacemakers, from face-to-face to remote control visits. We developed a remote control program of pacemaker recipients. We designed a support center for this remote control and developed clinical pathways to manage clinical and device-related alerts generated in these pacemaker devices. There are multiple collateral benefits, like the comfort for patients and relatives, the avoidance of hospital visits, the avoidance of fuel consumption, as it has mentioned, the avoidance of ambulance transfers, etc., etc., etc. And we have achieved the initiation of a serious and rigorous program for patient empowerment, with all these programs of education, with the APP and other things that have been started. And final comment, last slide. This project represents a clear improvement in health care quality and an improvement in quality of life of our pacemakers, with no doubt. I hope it will serve as a key element for the generalization of these types of procurement models. And what happens beyond RITMOCORE? Well, in our hospital, there is already an ongoing 6-year service contract called ADEL, regarding all other procedures and interventions performed in the arrhythmia unit not covered by the RITMOCORE. So we call us strong believers of the model, because all the activity of the unit, that is pacemaker implantation in RITMOCORE, but all the other procedures, ICD implantation, electrophysiology studies, and ablations are under the umbrella of this ADEL, another service contract that is already ongoing at the hospital. But we have already ongoing conversations with the hospital director, with the financial department, with the director of the cardiology department, to define the characteristics of a future RITMOCORE 2 program, as Hospital of São Paulo has done already with the ICDs. Belviche Hospital has 6 ongoing service contracts granted with ERD funds and next generation funds. So our hospital is fully committed with these service contracts. RITMOCORE has been a pioneering project that has opened the door to a whole range of digital transformation projects, and in particular, the Southern Metropolitan Territorial Management, where Belviche Hospital belongs, is betting on this type of projects that will lead to a substantial improvement in our relationship with the patient, as well as important organizational changes to adapt to all these new models. And that's all, and thank you very much for your attention.
Thank you, Ignacy. Can you hear me?
Yes, yes. One
second that I see that there is a problem. Okay. So now, unfortunately, time is running, and this latest presentation took longer than planned. So now the word is to Liverpool, to again Dr. Jay Wright, to Michael Filek from Liverpool, and to their provider, technology provider, Robert Hilton from Boston Scientific, UK. Then we will have a short intervention from Fernando Jara from Mutua de Terrassa. It will just right away, so with no, so from Liverpool to Terrassa, and then let's see if we can try to get everything in the next 20 minutes. Also maybe with some insights from Sofia Moreno from Valde, with the idea that we will shorten our roundtable 20 minutes. So the idea is to try to stick this presentation in this next 20 minutes. Sorry for this, but unfortunately we don't have more time to play with. Thank you. Thank you, Mike and Liverpool.
Right, yeah, from my part, I'll do a very short summary, but I think we're going to start with our fantastic technology supplier, Boston Scientific, and we have Robert Hilton joining us. So Rob, do you want to make a start?
Yeah, not a problem. First of all, thanks for inviting me along. It's great to be able to share our experiences. I will just pull up our slide deck. Hopefully everyone is able to see the presentation.
Yes, thank you, we see it.
Fantastic. Okay, so very briefly, obviously in the interest of time, just to quickly give an overview of myself. I've been working with the company for the last 12 years, primarily leading commercial responsibilities, both at a regional and a UK perspective. I'm more recently taking more ownership of the national contracting arrangements between ourselves and NHS supply chain and the national procurement framework. And prior to my commercial experience, I was in fact a clinical physiologist at Liverpool Heart and Chest. So have a decent understanding of the clinical considerations that have been described so far on the call. In terms of what RITMOCORE meant to us as an organisation, essentially it was these 2 points. It was to establish a procurement process which focused on the service provision in addition to the traditional supply of product, and to facilitate and address the increasing demands around remote follow-up specific to the pacemaker population, that I think has been highlighted already as being underpopulated in comparison to high voltage CRT and ICD devices. To provide some insight in terms of where Boston Scientific was and is as an organisation, and specific to service provisions, we have developed an array of solutions aimed at supporting customers beyond the provision of purchasing product. This can be broken down into 5 pillars under the banner of Advantix. This essentially falls under capital financing, so the support of investment in facilities and hardware, cath lab refurbishment, for example, performance optimization, so looking at service provision and increasing operational outputs and efficiencies, the development of services, something which we've experienced of in several of our key centres, and then looking beyond those core solutions, therapy solutions, so specific to AF, heart failure, etc., using various solutions. And then beyond that, obviously the digital space, which I think is something which is pertinent to the conversations we're having today around integrated software, digital apps, and remote patient monitoring. So it's worth highlighting that obviously these provisions, these services are readily available through a compliant route to market. So in relation to RITMOCORE, Boston Scientific ultimately took the decision not to submit a bid as a result of the following considerations. So primarily due to an inability to fulfill the requirements expected of a single provider, an inability to submit a collaborative offer. So I think we've touched on the fact that we've reached out to several third-party providers in an attempt to try and find a viable and workable solution, and unfortunately, we were unable to come to some sort of arrangement that we felt fit the requirements of the ask within the RITMOCORE tender. For us, no obvious compliant route to market in relation to the supply of competitive products and accessories. So certainly specific to the UK, there were challenges and are challenges, obvious challenges with regards to the supply of competitive products and service provision. Aligned with all this, obviously, there was the establishment and the mandate to begin to procure product through a single ODU compliant framework, which we now know to be NHS supply chain and the national procurement framework. Contract considerations, so some of the things that played out in parallel, which ultimately led to our decision. Brexit is a key one, obviously unknown unknowns at the time, so no one was quite sure what impact and the extent of the impact Brexit was going to have. There were just too many considerations that kind of, made it extremely difficult for us to kind of map this out with regards to what the next 3 to 5 years, and in all honesty, probably at that time, what the next 3 to 5 months look like post the Brexit or the decision to leave the EU. COVID, which followed closely after, had a huge impact in this space. Obviously, centres such as Liverpool Heart and Chest were forced, in effect, to find rapid solutions with respect to service provision and patient safety in the context of a remote environment. And so solutions had to be sought and realised in a quick time frame. From an internal perspective, obviously challenges surrounding supply chain, obviously as a result of Brexit, but also in relation to COVID and the increased demand on product, the ability and the need to ring fence various products in relation to the rollout of such a service in relation to remote care in the pacemaker space. Furthermore, and as I've already touched on, there were several viable models explored in an attempt to deliver on the premise of RITMOCORE, whilst we attempted to maintain contract compliance. And then also from an internal standpoint, there were anxieties in relation to existing business established. And I think, as Jay touched on earlier on today, around the sensitivities around price points and the cost of service implementation over and above the provision of product. And within the frameworks and the budgets that are established within the UK, how do we essentially square that circle? In terms of lessons learned, and this is just a final slide just to touch on some of the points already highlighted, but from an organisational standpoint, obviously there is the increased awareness of service improvement programmes, hence our Advantix portfolio, which is intended to address some of these needs moving forward. Obviously the challenges around diverse healthcare systems across various geographies and the unique demands which require bespoke solutions, you know, exploring how do we get to those solutions, and a greater ability to share best practice within, you know, some of our key accounts. So obviously linking centres such as Liverpool Heart and Chest to some of our other global customers to share best practice and drive innovative solutions. You know, the need and the exploration of exploring relationships and establishing deals with third-party providers, and you know what we are able to do in that space moving forward, and an ability, I think, to communicate and define the organisation's strengths and limitations with respect to service provision and procurement practice. So obviously knowing our limitations, but also understanding the landscape and the procurement processes in place, which, you know, may limit our ability to move forward on such initiatives. And then obviously from a local standpoint, perceived language barriers, it's probably worth highlighting that as part of the RITMOCORE initiative. We were primarily dealing with third-party ownership, and therefore we required translators and communicators to kind of help us provide context around what the implicit needs were within the RITMOCORE tender, which obviously led to miscommunication and some misalignment in relation to perhaps what was ultimately being searched for with respect to this process. So hopefully, obviously it's brief, but hopefully that provides you guys with an insight into kind of our experience, and I'll pass back to Mike, who'll be able to expand further from a customer perspective.
Thank you, Rob. Thanks for sharing your feedback and the lessons learned. That's really helpful. Jan, I think I'm still without a laptop, so if you would be so kind as to load the slides and I can talk you through them, please. Thank you. That's showing in small. If you could just make that a bit larger. Thank you. Brilliant. Okay, well, first slide. I'll give Liverpool's. I think Dr. Wright has had to attend to clinic. I'm Mike Phillick, Head of Improvement and Transformation. Next slide, Jan. So here's just a bit of background, and I won't labour the point. We're a very small hospital in UK terms, but a very large centre that specialises solely in cardiothoracic. So I think we may even be the largest centre now nationally. You'll see a long history of achievements, and I would just be interested to think what will happen in another 78 years. So if we look in the when the first open heart surgery was done in, was that 1964 to today, where will we be in a further 70 or 80 years? I'd be fascinated to see. RITMOCORE is just crack in the just starting to open up the minds to the possibility of some of the fantastic benefits that technology and innovation can bring to our patients. And you'll see more lately in our timeline, things like robotic surgery. Next slide, please, Jan. So we are highly accredited in the UK by our regulators. We're one of, I believe, 2 hospitals to be twice rated outstanding, and our patients rate us as the best. And we've achieved that accolade 9 out of the 12 years to 2018. Next slide. We serve that area highlighted. Where I am today is the smaller bit in red. That's the Liverpool and the Mersey. Cheshire is in yellow, and Wales, North Wales, in blue. You'll also notice we serve the independent Isle of Man. It's a very small population, but has a very unique requirement for cardiovascular support, which we provide. Next slide, please, Jan. Yeah, we are undergoing a major capital refurbishment of our catheter laboratories and increasing capacity to support not just the pacemaking and ICDs, but electrophysiology and TAVI and so on, all the full range of specialist tertiary services in cardiology. Our activity, you'll see there, in terms of non-complex pacemaking, the subject of RITMOCORE, approximately 400 new devices per annum, with 170 revisions, some of which will progress to ICDs. Next slide, please. So this is the one I want to spend some time on, and then I'll be finished after some lessons learned. So the reasons for joining, I suppose, echo everyone's comments today, and ours were, I suppose, no different, but this is our version of them. So our organizational vision is to be the best cardiothoracic center, both in terms of delivery of care and research. So that leads nicely into innovation. So we saw this as an opportunity to adopt innovation that was in the market already, and was innovation that we had successfully had in place in regards to our complex pacemaking for some years. It goes without saying, we saw an opportunity to not just improve safety and outcomes, but significantly patient experience, to improve the personalized element, which we heard Irina talk about at the outset. And everyone's mentioned, and certainly we've benefited from the increased detection of AF. And I would suggest more significantly that it's not about the increase, but it's as much about initiating the anticoagulation and anti-stroke measures much earlier than we would have been able to in the past. I won't labor the point. There are numerous reasons why we joined RITMOCORE, but skipping to the last section, we saw an opportunity to access transnational buying power and to overcome clinical resistance to change internally. For me, it was a proof of concept opportunity to prove that financially, clinically, operationally, and from a procurement perspective, that this was a model that would work. And then last 2 points, though, are very important for us as a hospital and us as a leading heart center. We saw it as an opportunity to engage on a wider footprint and ultimately scale up the innovations for the benefit of all pacemaker patients in England. Next slide, please. So we went about, as we've heard many of you describe as well, stakeholder engagement. Back at the outset of the project, we engaged with a full range of patients, representatives, doctors, cardiologists, physiologists, and identified through that process some key opportunities, all very much core to the RITMOCORE pillars. So remote follow-ups, which is, and importantly, integration with other pathways and integration across primary, secondary, and tertiary care. So lastly, in terms of needs, the pandemic point was one really about the pressing and urgent need to deliver the solutions that the innovations at pace and at scale. Next slide, thanks, Jan. Yeah, in terms of the experience, we heard the perspective of Boston and Medtronic also, and others, Jude's and the rest, we didn't receive compliant bids. Nevertheless, we were able to negotiate and conclude contracts in a RITMOCORE inspired and influenced way. And as regards that, some of the things that we've benefited from that stem from the RITMOCORE experience is around the contract monitoring. So traditionally just volume and price, which I've heard mentioned earlier, but we're now in a position where Boston, for example, Medtronic, are more responsive in terms of innovation. So offering that flexibility to give to the hospital and therefore patients in turn access to innovation and technology. Final point, really, we've just had great and responsive support from our supplier partners. Next slide, Jan. So major achievements, I think it was the implementing these innovations at pace was a really important achievement, mirroring our existing complex pathways. I think the two-way alerts, the kind of alert-based medicine and the way that that feeds into all of the RITMOCORE ethos relating to patient activation and being able to control and monitor your own conditions, and which leads nicely onto the increased detection point around AF. So all of that was as now are achieved. The digital platform seamlessly integrated with our existing case mix for complex, so that was a real benefit. In terms of lessons learned, Rob summarized quite nicely how there were some perceived or real obstacles in terms of the procurement. I've called procurement culture, so some misalignment of incentives and motivation, but equally willingness and ability to collaborate. So I think, summing that up, I think what we've learned is that there's a really high degree of partnering required that requires even greater levels of communication between suppliers, hospitals, and the network of partners that RITMOCORE envisaged we would advance the solution with. And then lastly, prepare for the unexpected. We've heard Brexit, that kind of messed our plans up slightly. It created anxiety and nervousness in the market. It created a great deal of uncertainty for us as a provider in terms of our contracting. So COVID-19, we know about, and our lack of compliant bids. These were all things we hadn't prepared for in terms of RITMOCORE, and it was unfortunate. But final slide, final point. I've seen we're running short of time. Basically, this slide simply says that thanks to RITMOCORE, we're now looking at the world in a different way when it comes to procurement, and as a huge learning for us, it has been tremendously beneficial in terms of our approach to future procurement. So the last 3 points there, I know we will be able to build into future discussions, not just for our hospital at provider level, but at a regional level. The idea of partnering and collaborating and shifting from a product exclusive price and volume to a service-based contract to embrace and adopt innovation at pace. And the last bullet is just to reflect that this doesn't apply only to cardiovascular or to pacing. It applies across a much broader spectrum of specialties. Thank you, Jan. That's the end of my presentation. I think you're on mute, Rosanna.
Can you hear me now?
Yes, Ken.
Yes. Oh, okay. Sorry. Okay. Thank you very much, Mike, and thank you very much to Boston Scientific, Robert Hilton, for your presentation. So now let's move on with Fernando Jara from Mutua de Terrassa.
Good morning.
Can you share your screen?
Yes.
We can see it. Thank you.
Sorry?
We can see it perfectly, so you can start.
For the presentation?
Yes.
All the screen?
Yes.
Okay, perfect. Good morning. I try to explain and to show now as briefly as I could our experience with RITMOCORE project. The Fundació Assistencial Mutua Terrassa was founded in 1900 as an insurance company, and since then has been growing and expanding its activity in the health field. Nowadays, its main pillars are the Hospital Universitat Mutua Terrassa and the network of primary care centers, but also holds geriatric, social, welfare, and logistics centers.
Fernando, sorry, we don't see the slides to move. We just see the first one.
Now?
No.
Now?
We see the first slide. Okay, good. Oh, yes,
okay, good.
Very good.
Okay, good. Well, nowadays, the main pillars from the Fundació Assistencial Mutua Terrassa are the Hospital Universitari Mutua de Terrassa and the 13 primary care centers, also as well holds geriatric, welfare, and logistical centers. The hospital is a middle-sized high-tech diagnostic therapeutic center agreed with the public health system of Catalonia. And the primary care centers are sharing the same electronic medical records with the hospital at the same times. The pacemaker unit belongs to the ICU, working in collaboration with the cardiology service. You can see here the main features and numbers. We implanted devices, make face-to-face follow-up by physician extra consultation, and in the last 2 years we are starting remote monitoring for selected patients with 2 platforms. We make as well other activities for support and assessment of the other service, and we don't implant ICD, leadless pacemakers, neither do all lead restrictions. This slide, you can see how the progression of the number of implant of devices has been increasing in the last years. Nowadays, this year, we are probably expecting to surpass 150 devices implanted. What was the rationale for joining RITMOCORE for us? When we started RITMOCORE, our current situation was the next. Purchasing office, both the devices. Nurses were employed just at the implant. We didn't have any kind of remote monitoring, and there were a total lack of feedback with the patients. On the other hand, the coordination care had room for improvement. What we expected with RITMOCORE, obviously, we expected a global change in the workflow of the system, from payment for the devices to a system with comprehensive service with patient-centered. We can expect it as well, obviously, a lot of improvements in our diary management, as you can see the main of them, and other time as being presented, well defined in the RITMOCORE project. As a buyer, VIMT participate in the management task of RITMOCORE in networking with the other partners. After several meetings and brainstorm, all the team together made the analysis of the current status, current problems, lack of remote monitoring, and the implications and role of the different actors professionals, nurses, administrators, and obviously patients in all the process. All of this make us to identify the needs we had. We shine in work, other teamwork of RITMOCORE manage each step and shine out the elements with the different specifications concerning to each lot. Finally, we defined common goals and needs for all the lots and specific goals and needs for each lot. All this work ended up to the call for tender and the later steps. The call for tender, unfortunately, in our case, was deserted. We consider that the split of global project in different batches give a very important weakness to the smaller lots, our case, by a loss of scale economy. That was an important point for explaining the situation. On the other hand, the price offered versus demands was lower in our lot respect to other lots. In that point, we decided to explore what was the opportunity for bid in another way our lot, and finally the legal option of a negotiated procedure was launched. The procedure has to be inside from the narrow parameters of RITMOCORE. He has to maintain the main pillars and the main structure and the spirit of the project. And in addition, we have to maintain the same budget that the initial call for tender. So we have to make an effort, an imaginative effort, and finally decided to offer in a way more attractive situation one lowering of the all the issues that were be feasible in order not to change the structure of RITMOCORE, as you can see in the slide. Finally, unfortunately, again, the negotiated procedure was deserted another time. No one brand happy for the procedure. Our analysis later, with feedback with the industry, told us first that the lot remained too much mismatch between price and demands, and second, the consideration that in a public procurement to accept too low price was risky for them, for the industry, as it could be demanded for lowering prices from other buyers. Anyway, despite TNT not being a procurer, RITMOCORE has favored along its management, starting of remote monitoring for some of our patients, promote starting for nursing staff for roles of devices follow-up, and improvement of some coordination case circuits with primary care GPs. And under the point of view of management of a PPI, RITMOCORE told us, knowing the structure, steps, and requirements of a PPI in the framework of European Commission, the usefulness and co-creation and teamwork for providing innovative ideas and improving an already established process, the advantage for involving the industry with sharing risk, the advantage of empowerment the patients in their self-care, and finally, to learn how to extract common points in very different health structures. That's all. Thank you for your attention.
Thank you very much, Fernando, Dr. Fernando Jara Clemente, for your presentation. And now let's make a bit change to the program. So we'll have right now the roundtable around policy briefing, results, and escalation of RITMOCORE PPI model. And while the insights from Valde, Sofia Moreno will be done just after. So try to recover some time. Some of the panelists can stay a bit longer, some others no, unfortunately. So let's try to have this roundtable right now in these 30 minutes, and let's see if then with some comments we can extend a bit longer, maybe with some of the panelists that can stay. The panel that we have, it's a really great panel, so I will ask the panelists to switch on their camera, and I thank you and I thank them to join us. We have Jenny Camaradou, that is she is the patient citizen advisory group of PP Community of Practice and OPAT patient consultant. We have Tony Gilabert, that he is the innovation director of the Consortium de Salut Social de Catalunya, that is a Catalonian group purchasing organization. We have Ivo Locatelli, that he is the strategic procurement, he is the project officer of the strategic procurement DG, industry, internal market, entrepreneurship, and SME, DG Grow of European Commission. We have Vasilis Tsanidis, that he is an innovation procurement advisor at the European Innovation Council, and we have Rosa Vidal, that she make part of the economic unit of Salut, that is a public Catalonian healthcare payer. So thanks to them for coming, for joining this roundtable. This roundtable is the fruit of a deliverable, one of the deliverable, one document that we're generating along the project, where we were looking at how the model of this RITMOCORE contract is scalable and ready to go to from the buyer side to maybe within their own within their own hospital, within their own setting, but also beyond to with other hospitals. So they went through a self-assessment, and then also we did the interview to this panelist. And at the end today, I asked them to prepare 2 questions. So I will make this question we'll share this question to everybody. So how policy making could contribute to wider adoption in healthcare of outcome-based and other form of risk-benefit sharing contracted as RITMOCORE. And the second question, what evidence such contracts should bring to support such policy making? And I will start to ask to Ivo Locatelli to comment on these questions, and then I will ask then to Vasilis Tsanidis, then I will ask Jenny Camaradou, then I will ask Rosa Vidal, and finally Tony Gilabert. So Ivo, the floor is yours.
Good morning everybody, and thanks for inviting me to speak to this panel. So the question basically is about how to foster the take-up of value-based procurement in Europe. There are now several examples which have taken place in a number of different countries, in France, the Netherlands, of course in Spain, as we have heard. I would say the first element maybe is really to showcase. There is always, we have to always consider the power of providing examples of people which implement by their own and pass all the experiences, all the tests, and explain all the hurdles and also all the benefits that this has carried out. So this provides any benefits on results. The other elements, I think, in an industry, in a sector which is extremely sensitive and delicate, as the health one, it's important to engage with all the relevant stakeholders, which means with the buyers, the providers, the payers, the suppliers, and also possibly the patients. This is important because it's important to clarify what is the case, what is why this approach is beneficial, what are the potentials, and what are the potential difficulties, and how they can be addressed. Of course, let's say, as every public administration, if I extend this concept also to the health sector, there is a lot of resistance to change, and that's why it's very important to discuss. Maybe the final element is relation to possible regulatory measures or standardizations, which are a bit difficult and delicate. Again, here I would suggest to take a very step-by-step approach and possibly testing initially, carry out some field testing using behavioral insight in order to see what is the most appropriate to, let's say, provide incentives to change by the relevant community and the relevant stakeholders. So that's all for the first question. I do not know if you want everybody to answer to the first question or to go for the both of them. I cannot hear you.
Sorry, maybe it makes sense to go for both of them because unfortunately some of you then will need to leave at 1 p.m. And so maybe we cannot have time to do the round, unfortunately.
All right, so basically the question is about what evidence should be put in contract in order to foster the diffusion of value-based procurement. I would say that the first one is really to look at ex post evaluation in elements, which can certainly contribute to this, and also maybe have a kind of always try to learn from experience and try to prepare for the future also in every single contract, so have a kind of longer term perspective. With this, I think I can give back you the floor.
Okay, thank you very much. Thank you. Vasilis.
Hello, good afternoon from my side. Thank you very much for inviting me to this very interesting event of RITMOCORE PPI Final event of PPI. Actually, I had the opportunity to follow this project while I was still in DG Connect, and I'm really happy to see that it is bearing fruits and it is already towards the end with a very important and successful results. Now. On the points that you raised, Rosanna, on the policy making, actually, I would differentiate between public buyers. I will focus on public buyers because there is also there are also private sector buyers, but now we are talking about public buyers and suppliers, because it is really important to keep an eye also on the suppliers' point of view. For the policy making, it is really important to have a framework system at different levels of governance for the encouragement and support of innovation procurement implementation. At national level, it is really important to provide incentives to the procurers, especially hospitals, especially after the COVID crisis that we faced in the previous years, and we are still facing, in order to perform more and better innovation procurements. Also, it is really important that the national governments are ready to be flexible in order to adapt any existing and obsolete regulation that actually hinders the deployment of innovative solutions that have been developed during in other procedures like PCP, pre-commercial procurements, or other R&D procurements. And of course, it is really important to provide guidance to the procurers in order to provide clear guidances for taking examples from the national laws and regional laws to enable to facilitate the work of those that are implementing innovation procurement. At regional level, it is really important that the region stands by to innovative procurers to provide any kind of support, and I would mention also financial support. There is a possibility to use, for example, structural funds budget in order to support the implementation of innovation procurements, and I know that Catalonia is doing that with its PPI program, and that is a showcase, a best case example for all Europe, at local level and organizational level. And I think this is the most important. Ivo spoke about it. cultural behavior. We need to view procurement, public procurement budget as a strategic tool that could help us tackle challenges in the long term. It is important that at organizational level, we act accordingly. And of course, at the European level, like this project that facilitates the networking between procurers in order to buy innovative solutions to tackle common challenges. Now, very quickly, because I know that time is running, to the private sector. It is really important that every framework support system on all these levels, European, national, and regional levels, provides support for awareness raising among the suppliers for the benefits and the business opportunities opened through innovation procurement, especially in the health sector. Guidance on how to innovative SMEs and startups on how to operate in the procurement world. It is very common that startups do not know anything about public procurement, and they don't know how to operate in this difficult for them world. We're talking for another planet here, especially for the startups. They think that they can do everything, but fortunately and unfortunately, public procurement has some specific rules for transparency, for equal treatment that have to be respected, and startups and innovative SMEs should respect them. And very important, we should provide possibilities to SMEs and startups to test and validate their innovative solutions on the services of public buyers. This is the best way, a pathway to commercialization of the developed innovative solutions. Very few words on the EIC, European Innovation Council Innovation Procurement Program. We developed an ambitious program that actually first facilitates the rapprochement, to bring together innovative buyers, procurers, public sector and public buyers with innovative companies through pitching events. We have a new project that is called InnoBuyer that actually will provide support, so please stay tuned, to public buyers and private sector procurers to test the solution through co-creation procedures, to prepare the tender documents, to perform market consultations, and to identify the public needs. So we will have launch calls, and we will offer financial support to procurers that would like to work with innovative companies. We are preparing a new initiative that will be announced in detail very soon, that we will create EIC communities with public and private sector procurers that are interested in the innovations that are developed by the EIC top-notch innovators. We will mainstream the co-creation approach with innovative companies, and we will provide assistance to EIC companies in order to be able to submit better offers to your tenders. So this is also a win-win for the innovators, but also for the public buyers, because they will receive better offers, and that could tackle their challenges. About the evidence, very quickly, what is important? Some clear results from the adoption of the innovative solutions. For public buyers, the modernization of public services. Of course, we need to have some tangible results from this approach, so better quality services. But also, this is not enough. We need also to have a better operational environment in the organization. For example, a better interaction between doctors and nurses in the health area. So this is also an important element that facilitates the implementation of innovation procurement. And of course, we are talking about public budget and the management of public budget, cost-effective solutions, especially in the long term. And for private sector, it is important to look at the commercialization of the solution through this specific vendor, but beyond. So the references that it's not only important for a supplier to take part only in this specific PPI, for example, but the references that this supplier gets from the participation in this PPI could help him find other potential clients for his innovative solution. And a cross-cutting issue, it's important to keep an eye and on the modernization of the existing regulation in order to enable the deployment of innovative solutions. So, for example, a specific role plays in the health area, standardization or other activities that facilitate the deployment of innovative solutions. Thank you very much, and apologies if I have taken more time than.
No, thank you, Vasilis, for the complete answer, and thank you also to Ivo, because really you are both bringing very interesting elements to the table. So now, Jenny, the floor is yours.
That's a very difficult act to follow, Vasilios, but just from a service user point of view, through taking part in the PP project, the Platform for Innovation Procurement project with European Hospital Alliance, a lot of us as service users, obviously we want preventative, personalized treatment, and innovation should be seen as an enabler to sort of access better care. But if you think of the usage of outcome tools to measure patient experience data or patient-reported outcome tools, quality improvement tools that help improve benchmarking, the system sort of, as previous speakers have said, can face challenges at the implementation level. And it's through this type of project we can actually embed best practice from a change management point of view that can actually essentially lead to better health equity and shared decision making, so that a patient in one European country doesn't have differentiated access, market access issues than another. But obviously Rome wasn't built overnight. So I think it's important to actually try to include patients in the identification of primary and secondary endpoints earlier on in the design of the actual prototyping of any medical device product. And it's projects like this that can actually work towards creating a shift in the actual way that the medtech community also perceives the value of stratified insight from a service user point of view.
Thank you very much. Okay, so very interesting points regarding the equity access to this innovation. So Rosa, the floor is yours.
Hi everyone, and thank you to letting me be here today on the behalf of Catalan Health Service, the public payer in Catalonia. And I will say just two things, because the previous intervention has said a lot. So from our point of view, Catalan Health Service has a great network of providers, which presents particularities and differences among them. Thus, as a providers, we can find very big hospitals. Some of them you know before in the previous presentations. Much smaller ones which work at local level, and for example primary health care centers. So on one hand, we know that the level of readiness for risk sharing contracts and the logistics needing to implement them are really high. So this could represent a remarkable barrier for small hospitals. These contracts depend on economies of scale, and where there are larger organizations, everyone can benefit more from achieving results. Thus, to maximize the probability of success of these contracts, the services and providers that participate have to be chosen carefully. We think that it has to be chosen carefully, and that's on one hand. And on the other hand, large hospitals have a purchasing team, invoicing, very powerful economic teams that are already engaged in this type of activity, which smaller ones do not have it. These contracts need resources to be implemented, that is human resources, training and knowledge, and any innovation and related advantages can reach the whole network if such adoption is supported and someone is taking the leadership to help those who has fewer resources. So it could be necessary to find a way to integrate more centers, taking into account consideration the diversity in size, capacity, governance bodies, and with the objective of sharing resources. So in conclusion, from our point of view, to tackle the access inequalities to these contracts that could exist nowadays, it could be very helpful to share all the available resources and experience that we have. So these synergies could reduce the transaction and operating costs of these procurements. And this is for the first question. And for the second question, just one idea, and we think that there is a very relevant aspect to take into account in these risk-sharing agreements, which is the definition of co-responsibility along clinical workflow defined in the contract. So depending on the task to be assessed, which stakeholder is responsible for what? Answering this aspect when the procurement is defined, we think that could be a great improvement. And that's it. So thank you for, I say again, thank you for letting me here today, and that's it.
Thank you very much, Rosa, for also your insights or inputs, very relevant. And before, Tony, before going to you, I give back the word from Jenny because she wants to add something more, and then Tony.
I think that my such a key point would be to try and look at creating faster regulatory paths for faster validation of sort of different pathways, so that essentially you can get more equitable care. And I think the United Kingdom is making quite a lot of interesting moves with regards to artificial intelligence with the regulators in that space that could provide an interesting blueprint.
Okay, thank you very much. So very interesting also this aspect. And Tony, so the word is yours.
Okay, thank you, Rosana, for this invitation as a member of the Catalan Health and Social Care Consortium, a group of health and social organizations, and a GPO for the National Health Service in Catalonia. Well, I just to remark that access to new technologies is a huge challenge for buyers, for regulators, and of course, it's necessary to sophisticate the way and the conditions for this access, for the purchasing, for the acquisition and the use. And the risk-sharing agreements are really, really useful for buyers and useful for providers, because it is an effective way to share uncertainty and avoid to block decision-making process. In my experience, the introduction of a new technology, the main problem is the uncertainty in the moment to introduce, in the moment to pay, and we have to minimize it, because when we don't minimize the uncertainty, what the decision-making policy do is do nothing, just wait and see. So we need to minimize that. And how can we do it? And this is the question, no? And first, and probably the most important policy making to take into account for me, is to generate an appropriate framework and good incentives. What does good incentives means? Well, if we pay products, hospitals will purchase products. And if we don't introduce incentive and financing models based on value and outcomes, it will be very difficult that hospitals spend its own money to receive less incomes. And I try to explain. For example, if I can introduce a new technology to avoid hospitalizations, but I receive the incomes for hospitalizations, I have to invest my money to reduce hospitalizations, and I receive less money because I don't have hospitalization. So this is very important to introduce the incentive to say, okay, we are National Health Service, we want outcomes, we want value. For this reason, we will pay not the product, we will pay the value. And this is something that I think it's really important to do. Other things to do, just we have to introduce the culture of outcomes and resharing. We have to introduce the culture of follow-up of use of technology, because sometimes we forget that the technology is not something we have to buy today. It's something that we have to prove that works. So that could go to introduce clauses in the contracts based on outcomes, and just a concept that we should put the focus much more in the evaluation ex post than the evaluation ex ante, because the maximum uncertainty is at the beginning of the use of this technology. So we should be probably less strict in the moment to introduce the technology, but very strict in the follow-up, and to assure that this technology works and we want to pay for that. So resharing agreements, I think that contribute to that, and my experience and the evidence that you ask us for that, my experience is in paying medicines based on outcomes through resharing agreements. And I think it has been a successful way to introduce innovative drugs and innovation technology faster, and assuring that the promised benefits are reached, and guaranteeing that we pay for value and outcomes, and not only for a pill or a product.
Very good. Thank you to all. Thank you very much. If I can summarize a bit what you said, and maybe, who knows, maybe we have still some minutes from some of you or from all of you to comment. I would start from the end. No, I would start from you, Tony, because I think it is very interesting what you are saying when you are highlighting that when we are introducing an innovation, really we should focus on the value. So we should have determined the value we want to bring, and then making sure that during the follow-up of the contract we can measure that value in the follow-up. And so also this should be also a way to somehow mitigate, or at least keep under control the uncertainty that we introduce when we introduce the innovation. And if we look at what Rosa was highlighting, well, if I want to highlight what Rosa was saying, this is very well connected, because so maybe when we are going to make such evaluation, such follow-up of this innovation, the value that it brings, we should also think carefully to what kind of buyers, the preparation of the buyer, the size of the buyer, the knowledge that the buyer has regarding the specific topic where we are expected to bring such value, because at the end, most probably, this influence the follow-up we are going to make, and why not also sharing, these kind of initiatives in a way that we have a mix of different sides, knowledge and resources that could support us to scale up and reducing operating cost. But by the way, still the stakeholder perspective is key, and really the intervention from Jenny was key. When if we go through this path, because at the end Jenny is saying thanks to this experience, and if we do it as now Tony and Rosa were suggesting, we could create different paths that enables us to access innovations, and this different path, why not, can support us in validating the innovation in a way that we can also adopt faster the innovation. So so also going to faster validation, and also why not, and this is very key, very relevant, support the access equity across Europe. So that not only in innovation maybe then is accessible somewhere in one country in Europe or in one region, but we can then, because we know the elements behind, when maybe the adopter, also the elements of the adopter, who characterize the adopter, who characterize the different stakeholders, we can also support that this innovation can be fastly adopted across Europe, and so accessible everywhere everywhere in Europe for the patients. And clearly a clear element to make it happen successfully is having the patient in the center from the very beginning, and take into consideration patient experience from the very beginning. And then we have Vasilis. Vasilis now was clearly setting, defining the different levels, that we need to ensure to make this adoption successful. He was at the end, he was talking about the companies, the different sides of the company, the SMEs, the support to SMEs that maybe they don't know how to bid, they don't know how to relate in a tendering process with the buyers, but also the buyers, the different buyers, how to stimulate the buyers, not only from knowledge perspective, but also how to maybe write a tender, how to make an open market consultation, so support to the networking, making sure that we have the three levels, national, regional, and local, that to support the public buyers to make it happen, and a framework system that define a way where the different players can move in a successful way and efficient way. And maybe making use also not only to some instruments that the European Commission has put in place, but also financially the RD funds, that's how we are doing here. And finally, we have Ivo, that was commenting as well, in making sure that we have measures in the long term, but to have this measure that we can support this in the long term, this kind of initiative. At the end of the day, it's important again, showcase, engage the stakeholders, and maybe while we are putting in place this initiative, started to get behavioral insights in a way that maybe we can standardize the way to do. And he was putting the emphasis, Ivo, regarding the resistance to change at a different level. And resistance to change maybe is also because, again, and it is something that came up to all of you to all these intervention, is also maybe because still there is some skills and knowledge that we need to spread in a way that the different stakeholders understand what can they do and how they can do it in which moment. And by the way, it's very important when we are talking about showcase, maybe take into consideration all the inputs of all of you, even including you, is also not only sharing the hurdles and the benefits, but maybe also taking into consideration different parameters or attributes of the buyers and the companies and the setting, and because maybe this showcase has some implication depending if you are a big buyer or if you're a small one. This is a clear example we have in RITMOCORE, or if you are from one region that you have Bismarck healthcare model, or you have other healthcare models. So depending on also the setting, this can really stimulate and create incentives for the adoption of innovation. Any comment still, since all of you are still here, I love it. So maybe Ivo, you want to comment on my small summary? You're mute. We cannot hear you. You are on mute, but is maybe a problem with your mic.
Now?
Yes, now yes, it works.
Sorry for this small hic. I think that you have captured all the right elements of this problem, which is very multidimensional and which touches so many different parties. I think that yes, in the last point that you have raised, you were talking about training. Indeed, training can be help in let's say creating awareness and creating knowledge about this approach. However, I think that we need something a little bit more than just training, because here it's a kind of a change of mindset, a change of culture, and this is not very easy. So you need let's say organizations which are ready to change. Which means not only at the operational level, it means a full organization which is ready to embrace a completely different approach to the pricing and the costing of service and, of course, of innovation.
Thank you very much. Thank you, Ivo. And Vasilis?
Yeah, thank you very much, Rosanna, for this very nice. Do you hear me? Okay.
Yes.
Thank you very much for this very nice wrap up of what all of us we said and we mentioned in our interventions. Actually, starting from what Ivo mentioned, yes, training is really important. It's a key. I mean, like the entry point to the process, but we need more, and we need, as Ivo said, cultural change, cultural behavior change. Actually, we are living in times of crisis. Repetitive crisis, and we don't have the luxury to stand by and wait for things to happen. We need to act now, and we need to have a clear plan in our heads on how to respond to this to what is happening around us. That's why I think it is really important to start thinking about concrete action plans at all levels that I mentioned, at national, at regional, and even at organizational levels, in terms of innovation procurement, in terms of modernizing the public services with innovative solutions for the benefits of the citizens. Thank you.
Thank you. Thank you to you, Vasilis. Jenny.
Yeah, I think everybody summarized the wrap up very comprehensively. I think it's a great initiative to be able to create monumental shift, but it needs to sort of happen in an incremental way so that it can be delivered for maximum benefit for the service users. Obviously, most patients don't really have familiarity with either health technology assessment or innovation procurement, so they're technical concepts to grasp at the best of times. And I think initiatives like UPATI or the EMI Paradigm program have done quite a lot to actually embed KPI framework-driven methodological tools that can actually measure the return of investment on patient engagement in preclinical early discovery studies and medical development. So I think innovators must not shy away from doing that and not just think about usability aspects in the integration of what actually matters to a patient. So you want to be able to see patient experience data inputted far earlier into the actual system, so that you can actually create something that the patient's going to stick to and utilize. And as previous people have said, that creates more equity across Europe.
Thank you, Jenny. Rosa?
Being almost the last one, it's really difficult to say something different and new. So Tony will have it much harder than me. But I think that, again, collaboration is the key to all of this, because sometimes we have a lot of experience in different countries, or even in the same country. In Spain, we have different autonomous communities, and all of us are doing different things. And I think that sometimes sharing, networking, and all these kind of events, when we can share and we can explain what works and what doesn't work, is really important to move on. So I will put again the focus or the main point in collaboration at every level, of national, regional, intra-European countries, and doing all of these resources in the same, you know, in the same place when everyone can learn. Because sometimes you have a great leader, but sometimes you are new. So you need training, you need knowledge, you need someone who leads you. So I think that collaboration is again a point to take into account to increase the probability of success.
Thank you very much, Rosa. Tony, you're the last one with the most difficult task.
No. Just I think that if we want to adopt outcomes-based contracting in healthcare, I think we should, and I should talk less and do much more, you know. And to do much more, this is I'm a fan of the bottom-up strategies. But in that case, I think that is very important, the perspective top-down. Because if we want to have some outcomes, we have to introduce the incentives and the way of paying for outcomes. And that's all. I'm pharmacist, and I've dedicated most of my life working as a manager in medicines and drugs and all of that. And for example, that pharmaceutical industry is real clear, the business, because we pay products, they produce products, and they give a very extraordinary value to the society with their drugs, and they earn a lot of money, and that's easy. So if we want to incentivize not the industry just like an entity, the industry of outcomes, the industry of processes, and the industry of generating new ways to innovate on that, we have to introduce the incentives for that, and we have to pay for that. And for this is I don't know if it's a good message for everyone, but I think this is my opinion, and I will be there for that.
Okay, thank you very much. But this is also is a relevant input, because in fact we need to be in action, no, to make it happen. Thank you very much. Thank you to all the panelists for being here. I see there is an raised hand. I would like to ask if anyone has some question from the audience to write it in the chat that has been enabled for this purpose. And in the meantime, apart of that, I really thank you for the panelists for having stayed with us during all the morning almost, and also having given to us their 20 extra minutes for closing this roundtable. I will ask to Sofia Moreno from Valde to to give us the insights from a supporting entity in this RITMOCORE project. Thank you, and thank you to all really for your time for being here. Thank you.
Thank you, Rosanna. Obviously, RITMOCORE has been intense since the very beginning to the very last day in collaboration and in learning experience. And I will reduce my presentation to the minimum because I think we cannot keep going like this any further. Well, I was planning to share with you some of the lessons learned during the execution of RITMOCORE. Most of them has been more or less addressed. Of course, all this is about changing mindset, and change management is capital. In RITMOCORE, also we need to change the industry value change and business modeling, and that has been tough because obviously there is resistance to change. So much that we got a judicial appeal during the tender process, and well, at the end it was successful, validating even furthermore the RITMOCORE model. But well, this is something that also deserves a good discussion. RITMOCORE is a successful example of digital transformation, and there are a lot of elements to be discussed there that are valid for any other experience in digital transformation, not necessarily addressing pacemaker. People play a main role in RITMOCORE, and we have fun learnings about how to implement public procurement. That I don't think is the moment now to go in with that. Well, maybe just to emphasize few challenges ahead. One is that, well, we have faced several force majeure situations like the last pandemic and the last problems with the international supply chain due to the war, etc. All these things has to be taken in account for long-term contracts. Now we have an extremely useful platform collecting data from people with pacemaker, but we cannot keep adding different platforms. If we start monitoring different things in people, we need to solve this problem and to find a unique platform to collect all data from monitoring. Monitoring, predicting, preventing is open wonderful possibilities to change the paradigm of care to preventive care, but at the same time, it provides so many data and so many alerts, and it could be also so demanding in human resources that could lock the system. So to have this to mainstream and to scale up monitoring for different pathologies and for whole population, we will certainly need advanced AI tools to manage all this. And we will need also suppliers able to integrate solutions not only for pacemaker but for more things, and that will imply also a full change in the value chain. But well, I think that just to remark that RITMOCORE has been a very rewarding experience, especially when at the end we could collect the people's feelings and experiences. And I want to remark that the clinical team in RITMOCORE is composed by risk-averse leaders. They are all doing crazy things, worse than teenagers. And it has been really a pleasure working with them. And if you want to know more, we will upload our summary of lessons later today, because we wanted to wait for this event in our website, and there you will find all the things that still we have not said. And thank you very much.
Thank you, Sophia. Before giving the last word to Ramon that he wrote up this long morning. I would like, we have the question from the audience that I think is also something relevant to RITMOCORE. So I thank you, Rafael de Andres Medina, that he is asking if the validation of innovative medical device require the active involvement of healthcare settings, how to avoid the bias if later on they become involved in PPI. That's a very interesting, a very hard question to answer. And but clearly there is an answer, and the answer is in fact trying to determine the N of patients, so also the N of different settings where beforehand where this medical device should be tested in a way that we can try to avoid as much as possible the bias. And in fact, in this moment, I would like to thank really the European Commission for supporting such projects, such initiatives, because they, thanks to these funding programs, they are stimulating the collaboration of different buyers in different healthcare settings. So all the experience that are now from Catalonia, from Aquas, we have been involved beyond RITMOCORE, have been multi-country, multi-settings, and this has enabled at least an initial validation, we don't end up with this unfortunately with these projects, validation already in a setting that is favorable for the industry, because already they can test their concept in different, again, in different settings with different kind of population. But this needs to go beyond clearly this experience. And so with this kind of contract, we favor an initial escalation model, but the escalation model is not done yet. It needs to go beyond really this experience. So we can validate, in this case of RITMOCORE, clearly we were not validating a pacemaker per se, we were validating the intervention of a complete digital transformation of the provision of healthcare service for patients implanted with pacemaker, and this validation has been done in 3 different hospitals, 3 different settings, 3 different sites, 3 different kind of population, but still clearly the concepts need to go beyond this. We cannot say we have demonstrated the full value just with this experience. That's for sure. And because of this, we are now saying this roundtable, no? What's more beyond this experience? Because this experience is not everything. We are clear on it. We are clear on it from buyer's perspective, because also the buyer's perspective is not the relationship, as Tony and Rosa were highlighting correctly, with the payer, but also from company perspective. This is, I think, is what I need to say. I don't know if anyone from the rest of the panelists, not only from the roundtable or from the day, from the morning, wants to add anything about this?
Rosanna, if
Yes.
I may,
Yes.
Rosanna, if I may, what is important to note is that validation is one step and PPI is another and different step. And how to avoid this risk of being biased, as our friend mentioned in our in the question, is not to be locked in specific technologies. In PPIs, it is really important to define and describe the need as it is. So in order to be able, you know that you already have a solution that may work for you, the one that was validated, but there may be other solutions on the market that may be equally and perhaps at a better, in a more cost-effective, could tackle the same challenge. So it is really important to describe the need in order to avoid references to specific technologies, in order to avoid lock-in situations also in the future. when you need to upgrade the solution to improve the solution during the contract implementation. We don't have the time to refer to this more in detail, but yeah, there are, this is the key message that we would like to pass, really description of the need and not technology specific references.
Yes, yes, that's clear. They need, in fact, all this kind of procurement, pre-commercial procurement or public innovation start from the description of the need and why, the business case, why we would need to address these needs, no? What value we expect of addressing these needs. Also, this is really key. I don't know if Ivo was willing to add something because there was a raised hand, but then.
No, not really.
Oh,
I just agree completely with what Vasily says.
Yes, very good. Thank you very much. I see, Rafael, that you are elaborating further. Maybe we can take this offline. Sorry, because really we are running out of time. And now we have Ramon that needs to close the event. But thank you, and we will contact with you and for the further discussion. Thank you. Thank you very much. Ramon, so the floor is yours.
Okay. Thank you, Rosanna. First of all, can you hear me?
Yes, very well.
Okay,
yes.
Thank you. First of all, I like to thank to all the attendees and participants in the event. Also, I like to thank to all RITMOCORE partners for the effort and the commitment throughout of all these years. And finally, I would like to thank to Aqua's teams, mainly in the last RITMOCORE stages. Rosanna and Ion, you had a very difficult role in these last stages of RITMOCORE, and you displayed skills and tenacity. So thank you all of us for this effort and commitment. Just for closing this event, some remarks, some ideas. First of all, if I'm not wrong, RITMOCORE is one of the first cross-border PPIs in the healthcare sector, partially funded by EU Commission, which has been completed. So I think that it's a clear message. Joint procuring projects are not easy projects. Cross-border procuring projects are complex ones. So we have to take care of all of these. Corona crisis, if I'm not wrong, Vasilis told us, Corona crisis highlight the importance not only of sharing the strategies, but also of sharing joint procurement and joint procurement processes. And I'm sure that projects like RITMOCORE will possibly become a must in the coming years. I'm sure you also agree that cross-border PPI cannot be an occasional situation, a fact, and in the midterm, the sustainability of this approach clearly requires systematization. So, for this systematization, it's quite clear that standardization of all the process has to be set up. We have, I think that at a global level of this standardization process has been already solved for PCPs, but I'm also sure that we still have a long way to go with the PPIs. For sure, the works, all the works and the projects promoted by EU Commission, and mainly all the activities and initiatives promoted by French government and the French EU presidents, mainly related with harmonization of the adoption and evaluation of digital solutions, will help us. But it's quite clear for me that we must go faster and further. So we need more RITMOCOREs. Second idea that I would like to share with you is an idea related with value-based procurement. The future sustainability of healthcare system will surely be multidimensional. And it's clear that value-based procurement will be one of the main variables in the equation of the economic sustainability of the healthcare sector. And finally, I like to point out an idea related to exponential technologies. Healthcare sectors will be one of the sectors where these exponential technologies will have a greater impact. Artificial intelligence, genomic sequencing, robotics, 3D printing. In the development of these technologies, digitization and dematerialization are some of the key stages, and RITMOCORE has offered us some key activities, some key ideas, some key strategies in order to deal with these stages, digitization and dematerialization. So, congratulations to all RITMOCORE partners. Thank you for attending the event, and good afternoon and good luck. Thank you, everybody.
Thank you, everybody. Thank you, Ramon, for your words, and thank you. So the event is done, and thank you really for being up to here, although to some delays, to all of us, because it has been great to have you here, the audience, the attendees, and the panelists. Thank you very much.